Guardians of Caribbean Health, the vital role of family physicians. Across the sun-kissed islands of the Caribbean, family physicians stand as pillars of their communities. They are the trusted caregivers who know their patients by name, their histories, and their families. These dedicated professionals provide comprehensive medical care throughout their patients' lives. From the bustling streets to the tranquil shores of the Caribbean islands, family physicians are the first line of defense against illness. They treat a wide range of conditions, from common colds to chronic diseases. They are also instrumental in preventative care, promoting healthy lifestyles and early detection of potential problems. The importance of family physicians extends beyond their clinical skills. They are deeply embedded in their communities, understanding the unique cultural and social factors that influence health outcomes. This intimate knowledge allows them to provide care that is both effective and culturally sensitive. In a region facing challenges such as limited healthcare resources and rising rates of chronic diseases, the role of the family physician is more crucial than ever. Their dedication, compassion, and expertise are essential for building a healthier future for the Caribbean. A legacy of care, the Caribbean College of Family Physicians. For over 2 decades, the Caribbean College of Family Physicians, or CCFP, has been a driving force in advancing family medicine across the region. Established in 1987, CCFP is dedicated to improving the health of Caribbean people by promoting and maintaining high standards in general practice. The organization achieves this through education, advocacy, and fostering a strong network of family physicians. At the heart of CCFP's mission lies a commitment to people-centered, continuous care. This approach recognizes that healthcare extends beyond simply treating illness. It's about understanding the individual needs of each patient and providing holistic care throughout their lives. CCFP provides its members with valuable resources, including continuing medical education, professional development opportunities, and access to the latest research in family medicine. These resources equip physicians with the knowledge and skills they need to provide the highest quality care to their patients. Through its unwavering commitment to excellence in family medicine, CCFP plays a vital role in shaping a healthier future for the Caribbean. Its work empowers physicians to be effective leaders and advocates for the well-being of their communities. Global Impact, Regional Action, CCFP's partnership with WONCA. The Caribbean College of Family Physicians recognizes the importance of collaboration in addressing global health challenges. CCFP is a proud member of the World Organization of Family Doctors, or WONCA, a federation of 131 member organizations representing over 500,000 family doctors worldwide. This partnership with WONCA provides CCFP members with access to a global network of family medicine professionals, fostering the exchange of knowledge, best practices, and innovative healthcare solutions. It also allows CCFP to contribute to the development of international standards for family medicine education and practice. CCFP's commitment to regional action is evident in its active involvement in shaping health policy in the Caribbean. The organization has been instrumental in key health policy meetings, including the Nassau Declaration on Health and the Port of Spain Declaration. These declarations address critical health issues facing the region, such as non-communicable diseases and the social determinants of health. By actively engaging in regional and global health policy discussions, CCFP ensures that the voice of Caribbean family physicians is heard and that the unique healthcare needs of the region are considered. If you are a family physician committed to improving the health of the Caribbean people, we encourage you to join the Caribbean College of Family Physicians. CCFP membership offers numerous benefits, including continuing medical education, professional development opportunities to enhance your leadership skills, advocate for your patients, and contribute to the development of healthcare policies. Research and publications. Global connections. Join the Caribbean College of Family Physicians today, whether by direct membership, by chapter membership, and be part of a movement that is shaping a healthier future for the Caribbean. Together we can make a difference. Become a member and make a difference.
Good afternoon. Thank you so much, everyone, for joining us today for day 2 of our pain management webinar series hosted by the Caribbean College of Family Physicians Jamaica chapter. I'm going to hand you over now to our moderator for today's session. She is Dr. Eileen Standard Goldson. She's a respected Jamaican family physician and executive board member of the Caribbean College of Family Physicians Jamaica chapter. She's known for her strong commitment to patient-centered care, preventative medicine, and advancing primary health care across the region. Through her leadership and advocacy, she continues to support clinical excellence and professional development within family medicine. Your moderator this evening, Dr. Aileen Standard Goldson. Over to you, Doc.
Thank you very much, Mr. Heron. Good afternoon to all, and welcome, and thanks for taking the time out on this Sunday afternoon to spend with us. This is part 2 of the Caribbean College of Family Physicians Jamaica chapter workshop entitled Practical Approaches to Pain Management in General Practice, Addressing the Common and the Complex. I know that everyone in the room at some time or the other has experienced pain of some type, and we all know how debilitating pain can be. On a personal level, and certainly on a professional level, we know that sometimes when our patients present with pain, it can be difficult for us to discern exactly what the root cause of that pain is. You had, those of you who were in the session on Thursday would have received some insight into some types of pain. And today we are going to look at 4 other areas related to pain. So welcome to you all. I know that as usual, this will be a very instructive, educational session as we have 4 eminent colleagues ready to present to us. Before we go into the scientific presentations, I would ask Mr. Heron to share with us the college prayer.
Grant me the opportunity to improve and extend my training, for there is no limit to knowledge. Help me to correct and supplement my educational deficiencies as the scope of science and the horizon widen each day. Give me the courage to recognize my daily mistakes, so that tomorrow I may see and understand more clearly what I could not comprehend in the dim light of yesterday. Bless me with a spirit of devotion and self-sacrifice, that I may treat and heal thy suffering servants, prevent disease, and preserve health to the best of my ability and knowledge. Grant that my patients may have confidence in me and in my art, and that they may follow my counsel and guidance. Grant that neither greed for gain, nor thirst for fame, nor vain ambition may interfere with my work. May I see in the afflicted and the suffering only a fellow human being in need. Amen.
And we all say amen. And in that vein, as we get ready to listen to our scientific presentations, we are going to have greetings and a program overview from the President of the Caribbean College of Family Physicians Jamaica chapter, Dr. Seni Ananuju. Dr. Ananuju.
Good afternoon, everyone, to our specially invited guests, Doctors Mike Mills, Christopher Daly, Jordan Eaton, and Kelvin Metallo, distinguished colleagues, our sponsors, IT and technical support personnel, Mr. Samuel Heron of Oldgate Solutions Limited, the Caribbean College of Family Physicians Administrator, Mrs. Lynn Thompson Hyatt, friends, ladies, and gentlemen, a pleasant good afternoon to you all. Pain is an unpleasant sensation which we all have experienced at one time or the other during our lives. It is subjective, personal, and multi-dimensional experience, and hence requires a multi-dimensional approach. The International Association of the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This afternoon, we pick up from where we left off last Thursday evening as we continue to explore some of the practical approaches to pain management in general practice while addressing the common and the complex. Consequently, the focal points of this afternoon's discussions include chronic abdominal pain and pelvic pain, psychological dimensions of pain, as well as exploration of practical approaches when prescribing for patients during painful episodes. Today's CNB activity put on by the college is pursuant to the college's mandate, which promotes the enhancement of knowledge, skills, and lifelong learning that has exemplified the practice of medicine throughout the ages. This afternoon, we are pleased to explore pain in its manifestations and management. Today, we have with us a cadre of distinguished, knowledgeable, and experienced speakers. Dr. Mike Mills, consultant gastroenterologist, Dr. Christopher Daly, consultant obstetrician and gynecologist, Dr. Jordan Eaton, senior psychiatric registrar, and Dr. Kelvin Metalo, consultant anesthesiologist. Thanks to the planning committee of the Caribbean College of Family Physicians Jamaican chapter for inviting them to share their time, talent, knowledge, experience, and expertise with us. I am confident that we will be well informed and enriched by their presentations and subsequent discussions. Doctors Mike Mills, Christopher Daly, Jordan Eaton, and Kevin Metelo, a wholehearted welcome to you all. A special welcome to our members and all other attendees who continue to support us. As is often said, it takes cash to care, and a meeting such as this could not have been possible without the generosity of our sponsors, Facey Pharmaceuticals, Health 2000, Servicare Distributors Limited, Indus Life Sciences Limited, Abbott Nutritionals and Viatris. On behalf of the college, I welcome you all, invite you to sit back and enjoy the presentations. Thank you, and as always, God's richest blessings.
Our sincere thanks to Dr. Seni Onanuju, our president, for those opening remarks. As she has outlined, we do have a very distinguished group of presenters this afternoon. And without further ado, we are going to go in the first scientific presentation for the afternoon by Dr. Mike Mills. Dr. Mills is a graduate of the University of the West Indies. He did his DM Internal Medicine program at the University of the West Indies and completed his subspecialty training in gastroenterology at the Royal Infirmary in Edinburgh, Scotland. He holds certification in gastroenterology from the Royal College of Physicians. He is an associate lecturer in the Department of Medicine, University of the West Indies, a member of the Association of West Indian Gastroenterologists, the American Society of Gastrointestinal Endoscopy, a fellow of the American College of Physicians, and also of the American College of Gastroenterology and of the Royal College of Physicians, Edinburgh. He is a past president of the Association of Consultant Physicians of Jamaica and governor of the American College of Gastroenterology for the West Indies chapter. He is a volunteer member of the Jamaica Cancer Society and has participated in numerous public awareness events and media activities covering digestive diseases with a special emphasis on colon cancer screening and liver disease. Today, he's going to speak to us on chronic abdominal pain, something that we see very commonly in our general practice office. Dr. Mills, over to you.
Thank you very much. Appreciate the opportunity to present again to this group. Congratulations to the college on putting on another of your excellent educational symposia. So this afternoon, we're going to focus on the matter of chronic abdominal pain. And to this end, we're going to be looking at just a few areas. There are a number of diagnoses which need to be entertained when talking about chronic abdominal pain, but we don't have time to speak on all of them. Okay, so we're going to have two cases. I know there was supposed to be a pre-test and post-test, but that aspect will be presented to you at another opportunity. We're still going to go through the cases because they're, I think, a little bit helpful in trying to understand how to look at chronic abdominal pain. So the first case, a 32-year-old female presents with her male partner with abdominal pain for the past 3 months. So she comes to you, she says her pain has been persistent, mid to upper abdomen. It's associated with a feeling of incomplete emptying. So no associated nausea, no vomiting, no diarrhea. She doesn't say that there's any blood in the stool, and she doesn't have any weight loss. No chronic illnesses, a history of asthma in childhood, but not very significant. No history of pregnancies. Her menses are normal. She says the pain is severe at times, quite severe, enough to send her to the emergency room twice in the last month. And by the time she comes to you, she's had an ultrasound done. It was normal. And she had a urine test done, which was a dipstick, which was also normal. She received Baralgin when she went to the emergency room, and this was given IV, in addition to some kind of PPI, fluids, the usual cocktail for pain, and then sent home on Baralgin. So that's the first case. And the question that's associated with this scenario is, what, in your estimation, is the next best investigation to order? Is it a contrast CT abdomen of the pelvis, abdomen and pelvis? Is it an upper GI endoscopy, a colonoscopy, celiac antibodies, or none of the above? Okay, second case. 68-year-old female, so an older individual, retired librarian. She's been having low abdominal pain for more than 10 years. But she says that the pain goes whenever she takes ginger tea and when she passes stool. It's not a lot of stool that she passes, normal amount according to her, but she does drink a lot of tea to get the pain to go away. Past history, so she's had her appendix out, she's had her uterus and ovaries out. She said for small fibroids, but the indication for doing that surgery was actually for pelvic pain. So she had pelvic pain, and they thought, okay, maybe whatever reason could be related to the fibroids. She had her TH done. That was the indication she reported. Allergies to aspirin. She says she's allergic to alcohol, Voltaren, and shellfish. And when you ask her, well, what do you mean by allergies? She said it feels as if her head is coming off. There's a history of constipation, according to her, many years, varying stool sizes, but no real alarm symptoms. So she's been to the clinic for this, but she wasn't given anything for the pain that she's been having over the time. So she actually said that she asked for at least Baralgin, and she takes that intermittently. So again, the question here, what do you think is the next best investigation? Contrast CT abdomen pelvis, upper GI endoscopy, colonoscopy, celiac antibodies, or none of the above. So these are the two cases that we're going to try and figure out. So what is your diagnosis? That's the usual question we're faced with as doctors. Otherwise, what are we doing really? You need to make a diagnosis. And then from that, what investigations would you be doing to try and confirm your diagnosis and look at your differentials? What treatment should you administer? And if you want to refer, when should you think about referring a patient who's presenting with abdominal pain? So let's go back to the first case then. Remember, young female, 32-year-old, came in with her partner, says she's having pain for the last 3 months, ongoing pain, no nausea, no vomiting, diarrhea, just the pain. and it's severe enough, go to the emergency room. So, what is your diagnosis? And you can type these in the chat. I'll give you maybe a couple of seconds to just tell me what you think would be your diagnosis if you present, if this female presents to you. So, young female. So just tell me one or two people, or as many as possible, really. I'll just look through the chat quickly and see if you can tell me what you consider to be your diagnosis clinically. Gastritis, IBS, okay. Gastritis with outlet obstruction, okay. So quite a few gastritis, IBS. Anyone else? Endometritis, gastric tumor in big bold. Okay, yes. So things seem to be centered on the stomach. Reflux, yes. Dyspepsia. Okay, quite a few stomach GI tumor, yes. So the patient is presenting with abdominal pain, functional dyspepsia, gastritis with ulcers, ulcerative colitis, peptic ulcer. Quite a few diagnoses coming up. So let's see where we will be focusing our thoughts then. So thanks for that participation. Okay, so here are a few things that should run through your head when a patient is presenting with abdominal pain. Okay. And some of them you did mention, which is great. Some of them maybe not yet mentioned, but still, let's look at them. Gastritis or peptic ulcer disease, those tend to go together. Cholecystitis, subabdominal pain. Pancreatitis, another organ in the abdomen. Hepatitis also causes pain. Appendicitis, of course, causes abdominal pain. Gastric cancer, pancreatic cancer, colorectal cancer, and then disorders of the gut-brain interaction, of which IBS would be one. So let's look at each of these and see if there's anything which would help us to make a diagnosis. All right, so cancer, let's group them together. So the cancer-associated causes of pain, and gastric cancer was mentioned, but remember, pancreas is sitting pretty close, and colorectal cancer, of course, always considered whenever patients are presenting. So these are the things that would kind of run through your mind. And is there anything in particular which would suggest to you one or the other, or maybe none? So age, of course, 32-year-old female, so a young person. And when we think of young people, we don't tend to think of cancers, especially the ones of stomach and colon and pancreas, tend to be an older population. Okay, not impossible, but again, demographics suggest that maybe not associated with a cancer. And then other things, no associated nausea or vomiting. You'd expect if there's a gastric issue or a digestion-related organ issue, you should have some nausea or vomiting. Again, didn't report any of this. No blood in the stool, no weight loss, no so-called alarm signs or symptoms suggesting that a malignancy should be associated with the cause. And she did have some imaging as well. An ultrasound was done. So should have picked up if there were gallstones, for example. And of course, based on the duration of 3 months, you wouldn't expect her to be having appendicitis for 3 months with no other associated of other symptoms mentioned above. So not likely to be a malignancy. Clinically and epidemiologically unlikely. But of course, I'm sure most, if not everyone in here is going to say, yes, statistics are one thing, but we always have that one patient who is young and then all of a sudden has, a cancer, and you're like, oh, is this the one who's with me? Or am I going to exclude this one patient? Because you only need the one to go wrong for something to, really, really be a problem. So statistically, not likely, but it's medicine, so there are no absolutes. What are the other diagnoses to consider? Okay, gastritis, peptic ulcer disease, so the inflammatory ones, cholecystitis, pancreatitis, hepatitis, appendicitis were mentioned. So again, similar in terms of reviewing the history to kind of suggest where are we? None of these symptoms which suggest really should be an inflammatory gastric condition. So ulcers and inflammation really shouldn't be, but of course, subjective. you can't exclude it completely based on the history. So you still have to keep it on the back of your mind. Is this gastritis, albeit not as severe? Is it an ulcer? Cholecystitis, okay, we can take that off the cards. An ultrasound would have definitely told you about the gallbladder, even if there are stones or not. Pancreatitis, again, the profile doesn't really fit it. You can't image the pancreas on an ultrasound and decide, okay, that is not the case. But unless you pull up a risk factor for pancreatitis in this young female, why would she be having pancreatitis? Because autoimmune, for example, is there a history of some unusual drug exposure that you didn't get in the history or significant alcohol use, which you're not getting? So again, back of the mind, not quite, but not completely excluded. Hepatitis, again, none of the symptoms suggesting she didn't really localize the pain to the area of the liver, no history of jaundice, even though we still know that lots of times with hepatitis, you can get non-specific symptoms. And the only way you know that there's hepatitis really is by doing the blood tests. Appendicitis, of course, examination and the history and so on would have definitely suggested if that's the case. And so we can maybe safely take that off the cards. Disorders of gut-brain interaction. So irritable bowel syndrome, chronic abdominal pain syndrome, functional dyspepsia. These are the things that we refer to when we speak about disorders of gut-brain interaction. And this is the overarching term which has replaced what we used to refer to as psychosomatic disorders. So disorders of gut-brain interaction, or DGBI, of which the three that are relevant for this presentation would be IBS, chronic abdominal pain syndrome, and functional dyspepsia. So we need to consider them, of course. So disorders of gut-brain interaction, because there's an interplay between your central nervous system, so your brain, and your GI tract, a so-called bidirectional gut-brain axis. So these nerves which interplay between the central nervous system and your GI tract are largely through your vagus and your parasympathetic nervous system. And there's an interplay between stress and psychological comorbidities, which impact on your brain, which then impact on your hypothalamic pituitary axis through your autonomic nervous system and interface directly with your GI tract. This may also cause symptoms of disorders, sphincter function and motility, but also significantly for this presentation can result in pain. There's also a genetic component there, not well understood, but we recognize in twin studies that there is a significant connection between a gene profile and the impact on stress, and also a direct impact on genes on the GI immune system and GI gut permeability, and the ability to actually appreciate nociceptive or stimuli in the GI tract, which increases some individuals' propensity to having symptoms associated with DGBI. Then other things like GI infections. So what's parasitic infections most commonly, but also bacterial infections or viral infections of the GI tract can disorder your microbiome, which results in disordered microbiome stasis or dysbiosis, which can also cause an interplay in the production of nociceptive pathways and also produce excess gas depending on the types of disturbances in your microbiome, which may contribute to symptoms associated with this disorder of gut-brain interaction. Diet is another significant factor, which of course interplays directly with your intestine. So both ways are significant. Your GI function can affect your mood and other factors. And then your brain can also impact your GI tract. And this is the hallmark under which we have placed some of these conditions, such as IBS. So irritable bowel syndrome is defined strictly by the Room 4 criteria as being recurrent abdominal pain on average of at least 1 day per week of having pain in the last 3 months associated with at least 2 or more of the following. There's a relation to defecation. So individuals must have some association with their stool pattern. It's associated with a change in the frequency of the stool, so either increased frequency or reduced frequency, or a change in the form or appearance of the stool. So 2 of these, at least 1 day per week for the last 3 months. So of course, there's some strict criteria here, but this is important more so for research purposes and to ensure that you have homogeneous patients' populations when you're trying to trial new therapies, for example. But from a clinical standpoint, it's still an easily utilized definition to make sure that patients have pain, frequent pain going on for a long time, and is associated with some change in your bowel habit. There are different types of IBS, and you need to be able to characterize the patients into one category or other. So there's IBS diarrhea or IBS-D, IBS constipation, and then there's a mixed group. And then there are those who don't have a significant pattern who are termed IBS-U. And the way you can figure out, which category to place your patients in, sometimes it's helpful to show the patients this Bristol stool chart. And you can pull it up on the internet, have it on your screen if you use an electronic system on your phone, or print off a chart and ask the patient to just identify what type of stool do they have. So if it's IBS-C, then a quarter of the time or more, they should be having bowel motions that are associated with type 1 or type 2 stool, and less than a quarter of the time, they should be having type 6 or 7. So constipation predominant ones have the lumpy stools, sausage-shaped stools, hard stools, more than a quarter of the time or 25%, and not have a lot of watery stool. And the converse for diarrhea, so if they have more of the type 6 and 7 stools, so the watery stools, and less of the hard stool, less than a quarter of the time, then they're categorized as having IBS-D. And then if they have a mixture, so you can't really separate the two, then of course you're talking about a mixed picture, and they may flip pretty quickly. And then if you're unable to get a pattern from the patient at all, it may be characterized as being undetermined. So let's look at each of them. IBS-D. IBS-D or IBS diarrhea, these patients present with abdominal pain associated with increased frequency and reduced consistency of stool. And the differentials that we need to think about when we're trying to make this diagnosis include inflammatory bowel disease, and we use that as a broad term, talking about either ulcerative colitis or Crohn's disease or microscopic colitis for the most part. So am I talking about inflammation, or am I talking about IBS? Two different things, and we need to be mindful of that. Or we're talking about an infection. Now, usually we're talking about chronic conditions, so most bacterial infections would be short-lived. So we're talking about more parasites, for example. So immunocompromised patients, they need to be mindful of what's happening with your patients there. Are we dealing with strongyloidiasis, for example, in our situation in patients who have HTLV1? Are we talking about celiac disease, something that, again, patients do a lot of reading, and sometimes you wonder, okay, am I talking about celiac before I'm talking about IBS? Is the patient having a food allergy or sensitivity or intolerance? Again, history may help you there. Thyroid disease to be considered in this case because it's diarrhea, so hyperthyroidism might be considered. And of course, various medications can also cause diarrhea, so these need to be borne in mind. Some of the more unusual conditions to consider if your patient is having diarrhea and you want to consider IBS, you want to say, okay, am I not dealing with a case of small intestinal bacterial overgrowth? Or is this a case of pancreatic insufficiency? Or am I dealing with a rare neuroendocrine tumor, which is producing a vasoactive substance, which is causing diarrhea? What about constipation? So these patients, if you're trying to decide if the patient is having IBS-C, for the most part, you don't have many differentials to consider here. Once you've excluded the medications and so on, you really are concerned about pelvic floor dysfunction. And just as a reminder, so in the normal state, from your most extreme left cartoon in the resting position, your puborectalis muscle forms a sling around the rectum, which pulls it forward and forms this angle, which increases your continence, in addition to normal acting internal and external anal sphincter. And when you want to defecate normally, your puborectalis muscle relaxes, straightens that angle, your sphincters open, and stool passes. When there's pelvic floor dysfunction, there is dysynergic defecation. In other words, the puborectalis does not relax, so the angle is maintained, and your sphincters may or may not relax. So any combination of these problems obviously is going to have disordered contraction and contribute to constipation. And it's something which sometimes can be picked up on a rectal exam most frequently as your initial screening tool, even though more definitively you would require manometry. But again, it's a differential for your IBS, constipation. So let's go at the first quick case then. The young female presented with abdominal pain, mid to upper abdomen, incomplete emptying. Okay, no nausea, no vomiting. Ultrasound was normal. And then the second one, older lady, abdominal pain, and had constipation as a history. So how do you approach these patients? The first thing I want to get across to you is that when you're trying to make the diagnosis of IBS, it's not a diagnosis of exclusion. Okay, there's strict criteria to make the diagnosis in a positive sense. Even though, having said that, it is true that all these other tests that you're considering really should be normal. So you shouldn't be making the diagnosis of IBS if you're finding that the patient has H. pylori positivity with gastritis or has another condition like celiac disease or another test which suggests that there is something to explain the diagnosis, but it is not a diagnosis of exclusion. There is no lab or diagnostic confirmatory test, which again makes it very hard to actually be objective about the diagnosis, because we do like to rely on tests. So having said that, testing should be limited, not excluded, but limited, and should be in consideration of the diagnosis and the clinical situation. So if the test is going to be based on something that you found in a history examination, then yes, go ahead and order that test. So what are these tests? Depends on how the patient presents. If they present with diarrhea, CBC, fine. ESR, CRP, so your inflammatory markers, because you want to exclude your inflammatory bowel disease. A fecal calprotectin, this may be a test that maybe you're not as familiar with, but we use it very commonly to monitor and manage patients with inflammatory bowel disease. So if there's inflammation in the colon, you can do a stool test, and it's available locally from our labs. And it will determine, for the most part, if the patient is having an inflammatory condition or IBS. Now, it's not 100% sensitive for inflammatory bowel disease, but a negative fecal calprotectin puts you on good grounds to decide that you're dealing with IBS and not IBD. So it's a good test to use in a patient with diarrhea. Stool overcysts and parasites. Yes, you can send it, even though we just said that parasites are an uncommon cause in our situation. But of course, it's a test which is helpful in excluding a cause of long-standing diarrhea, which is what we're dealing with. What about celiac antibodies? So the celiac antibody that we tend to rely on is your anti-tissue transglutaminase, IG component, and it is available locally. It is something which you can request if you suspect clinically that your patient has gluten sensitivity, if they have celiac disease, which, to be fair, we have not been picking this up locally in the patients that we do test. We need to do some genetic studies locally to see if our population is predisposed. But of course, with our patients coming from all over, you can have potentially a patient who has celiac disease, and it's something that you can test for to be definitive. What about constipation? So this patient is having constipation. What tests should you really be sending them for? CBC, again, pretty straightforward. And thyroid test, as we discussed, hypothyroidism potentially could cause constipation. So maybe these are the only tests that might be justified in such a patient who you've had a complete history. Imaging, of course, you'd want to look into the abdomen. So what tests would you want to consider? An ultrasound, CT scan, barium meal, barium enema, so many tests, MRIs, upper and lower GI endoscopy, small bowel enterography. All these tests are available. The question is, when are you going to be pulling out any of these tests? How many tests should you order? When do you stop testing? What are the indications for these tests? Diagnostic uncertainty. There's no doubt that most times when we're sending for testing, we're unable to confirm our suspicion based on history and examination. And so we want to get some kind of objective evidence, and radiologically or otherwise, this is useful. And this is mostly or number one indication for sending for tests. So it is a valid reason, but it can't be the go-to. It can't be that you're sending for every test. Common doesn't mean always. And we spoke before about, are we going to send our 32-year-old for colonoscopy, for example? Have we seen 32-year-old with colon cancer presenting abdominal pain? Yes, it is true. And of course, as doctors, we're always thinking, well, what if this patient is that one patient? And so that may be a reason for you to go and send your patient for testing. Again, I'm not going to, at this moment, say, don't send or send. I know that these are the reasons why we do it, however. Sometimes the patient requests. So the patient comes in having read, they're all exposed these days to different sources of information, some of them AI assisted, and it recommends, okay, you should do this test. So the patient comes and says, okay, doc, I want this test done because I'm having pain. How do you get out of that? Sometimes you do the test because you just want to reassure the patient. You're convinced, okay, it's not pancreatitis, but the patient just is not leaving your chair and you want to get this test to say, okay, look at this, it's negative. Sometimes you want to reassure yourself. You just want to do the test to make sure that you feel good, that you're not missing something. Is that a valid indication for testing? Maybe, maybe not, but it's something that we often face. Very often, your testing should be warranted on physical exam and history. So if you're doing it based on this, solid grounds, no problem. Sometimes otherwise, for argument's sake, if the patient is having abdominal pain, you think it's IBS. Do you need a colonoscopy? No, you don't need it to make the diagnosis. It's going to be normal. But should you do a colonoscopy still? Well, yes. If the patient is at age-appropriate stage for screening, then you will request a test to cover that screening, not necessarily to make the diagnosis, however. So in that setting, it is appropriate to request. This can be a challenge because you need to be careful that you don't fall into the thinking of patient is crying wolf. So they present to you many times with abdominal pain, and it is true that at some point they may develop a condition which is not their IBS. If you always think, okay, I'm not going to send him for testing, you may not recognize when there's a change in the symptoms, which then warrants testing, which is why it's always important to do age-appropriate screening and to take a thorough history and physical examination. So then for the diagnosis, make your diagnosis of IBS a positive diagnosis, not a negative diagnosis. You have your criteria, 3 months of pain, 1 day per week, associated with stools, and a change in either the form or shape of that stool. It's going to take time. IBS is not an easy diagnosis, and it's not so good to make it in your first interaction with the patient. You have to get buy-in. You need to listen to your patient sincerely. Symptoms are real. Please don't tell the patients that it's in your head or you're making it up. It's not a good place to start, and patients will not take kindly to it. There's going to cause some resistance. It's not something that they make up. It's a real condition. Patients' pain is impossible to measure, but they do experience these disorders of gut-brain interaction, which make the pain real. So don't use words like it's in your head or making it up. The psychosocial exploration that's necessary to make the diagnosis and to effectively manage is going to be difficult to initiate, especially if you're not used to having the conversations related to psychological issues. Sometimes the patient gives you an opening because they will come to you and say, it's not in my head, doc, I'm not making it up. Sometimes it's good to ask the patient, well, what's making you say this? And that allows you to get into some of the diagnosis that you need to get into in terms of the psychological aspect. Be sensitized if the patient is accompanied into the consult room. In terms of the profile of patients, they tend to be female. They tend to be accompanied by a family member, could be their partner. Sometimes this impacts the way the interaction happens. They may not be able to reveal certain information to you. And so it may be that you may be sensitized enough to have a discussion in absence of that individual to get more information. There might be a history of anxiety or depression or post-traumatic stress. These are not uncommon. The symptoms may be related to environment. So when you speak to the patients, you find that only when they're at work do they have pain? When they're on leave and it's protracted leave, they may have resolution, and as they're returning to work, the pain returns. It may be around exam time, for example, if that's the age group of a patient, that type of thing. Insomnia, another symptom which may be helpful in building your case. Severity of symptoms with short duration and polar opposites. So if the patient says, okay, I'm having constipation for 2 days and then suddenly I'm having diarrhea for 1 day and then the next day is constipation, those things will tell you that it's not an inflammatory condition you're dealing with. This is something which may be related to IBS, for example. Bear in mind that with all this, it can still be difficult to interpret, and time is an important factor in making the diagnosis, and the accuracy is dependent on chronicity. That's why the 3-month period is there. So it's going to be difficult if you're seeing the patient for the first time and they've never been seen anywhere before. Don't feel too badly if you're not making the diagnosis firm, but you can still entertain the possibility once you carry out further checks. So let's say you've made a diagnosis, you need to be treating. Your treatment is heavily dependent on identifying the symptom that is most bothersome. So is it pain? Is it constipation, diarrhea, or bloating, which frequently accompanies IBS? With regards to pain, try to avoid NSAIDs because you're going to be treating for long term and the complications associated with NSAID use can be problematic. Codeine can be useful, although if patients have constipation as a predominant issue, using it is going to exacerbate the issue. We find that Baralgin is usually a go-to drug for most individuals, which can be useful. Antispasmodics, yes, they're available. I'm not going to say don't use them, but the evidence suggests that they're not as helpful. Acetaminophen, they're benign, oftentimes not as helpful. PPIs, again, also not as helpful. The medications which have shown benefit are tricyclic antidepressants, so low-dose amitriptyline, and SSRIs. If it's constipation symptom, diet, there's so many laxatives available. Don't hold off the laxatives and don't spend too much time trying to figure out, okay, which one am I using? There are so many. Use your laxative, try and achieve a bowel habit. Encourage the patients to be consistent. And if it's very severe, sometimes we use PEG solutions because they're very effective. If it's diarrhea, then definitely loperamide, not an issue because you're not dealing with an inflammatory condition and it's helpful to control symptoms. Dietary triggers, so the patient may identify specific foods. Those things you need to go through the history and eliminate those things from the diet, even if you're not convinced that there's a mechanism behind it. And then environmental triggers as well. So as we spoke about, stressful events or situations may trigger the symptoms, and individuals need to be mindful about how to manage the symptoms around there. Bloating is a significant feature. So something called a low FODMAP diet is something that maybe you can be familiar with. That stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And these different food groups are responsible for most of the bloating that individuals with IBS may have. And so reducing the FODMAPs may be helpful in improving bloating. And there are lots of different foods in the different categories. So if you have this again as a chart in your office and you want to manage bloating from a dietary standpoint, then this is a good place to be. Your gut microbiome also useful in managing bloating. So whether it's antibiotics, prebiotics, probiotics, and antifungals, the reality is that the data is not as convincing. The only antibiotic that has been shown to be helpful in bloating definitively is rifaximin, and we don't have it available locally. We have used metronidazole or quinolones, low dose, short duration, can be helpful. Probiotics, prebiotics, peppermint. These are all things which the data is not as robust. They do play a role in gas production in terms of the microbiome, but it's incompletely understood. And so at the moment, it's not quite going to be as helpful. Not all bloating, however, is gas related. And this concept of abdominal phrenic dyssynergy is something that you need to be familiar with. So very often the patients come to you and they show you, they say, oh, look, I have a 20 or 40-week pregnancy belly. and they show you pictures and you're wondering how they get so much gas in there. And then they tell you it goes by afternoon or something and it didn't pass wind or belch or anything. So what's happening really? And what's happening is that normally as you breathe and eat and do your daily activities, your diaphragm is moving and your abdominal muscles, the wall is contracting. In a normal situation, your diaphragm elevates and your abdominal wall contracts. And this happens after a meal, which prevents your abdominal contents from protruding. In individuals who have this abnormal reflex after eating, they conversely contract the diaphragm and relax the anterior abdominal wall. They basically stick out the belly, for want of a better term, but you know, understand what I mean. And this produces so-called bloating, and it's something which needs to be borne in mind. Biofeedback is a good way to combat this approach, and it's something which we need to get into more locally in patients who present with bloating. There are different relaxation techniques and so on, which are helpful. Cognitive behavior therapy at the end of the day must be a part of most of your IBS or functional or DGBI conditions, and it's either done either with yourself or in conjunction with a specialist. So when to refer? Alarm symptoms. If the patient is having alarm symptoms, you definitely need to get on top of that. If it's not you doing the investigations, send them on. Frustration. Chronic abdominal pain is not an easy thing to manage. If you get frustrated with the patients, try and send them off. Don't beat yourself up too much. There are lots of different individuals who may be able to take the patient forward, whether it's the GI or surgeon, gynecologist, psychiatrist, psychologist, nutritionist, or allergist. Again, there are different stages, and it does take a long time to get on top of the diagnosis, and different things may need to be attempted before you can establish some level of control over the pain. So don't feel too badly. So let's look at our cases then. The female, young female, abdominal pain, 3 months, upper abdomen, normal ultrasound, urine tests, got some baralgin. What tests do you want to do? Well, I put it to you that none of these is the next best test, okay? And I hope you understand why. So it's not that you can't do any of them, but it's not going to be helpful, okay? And I know that it's still going to be difficult to resist doing some testing, but there is no best test. And if you're in another population, celiac antibodies might be helpful, but in our population, it's not a cost-effective way. What about the second case? Older female, abdominal pain for 10 years. She had previous surgeries, history of pelvic pain, questionable history of allergies. What is your test here? Again, colonoscopy. Not because of the pain, but because she's never had screening done. And so, as an opportunity to complete screening, you would select as your next best test. Outside of that, you would not really be able to suggest that there is any particular test. So chronic abdominal pain then is something which we grapple with on a daily basis. It is not something that is easy to manage. The diagnosis, however, needs to be considered carefully based on history and examination. Investigations have a role. They should be limited, however. Try not to over-investigate the patients. Feel confident that having made the diagnosis, that the patient is in the right category, manage the symptoms that present, and be prepared when possible to refer if you're not quite sure how to move forward. Thank you.
Thank you very much, Dr. Mills, for that very comprehensive treatment of chronic abdominal pain. You should us through a step-by-step analysis as to how we would look at the history and examination of the patient, introduce to some of us the concept of disorder of gut-brain interaction, and especially went through IBS in quite a lot of detail. I'm sure some of us were seeing the Bristol stool chart for the first time, and that could really be an interesting tool in our day-to-day practice. Thanks also for the advice retreatment, especially where we have bloating and your advice against over investigation, which is always a trap that we can fall into. As you mentioned, the patients can be quite persistent. So we do have to remember that sometimes we do need to refer, get another opinion, see if we're missing anything, but try not to over investigate. So thanks very much for that talk. And I'm just looking, are there any, we have a session for questions and answers at the end.
Okay,
But
no problem.
In the meantime, if there are any questions, please put them into the Q&A tab at the bottom. We'll ask Dr. Mills to monitor that. And if he wants to answer any of them in that vehicle, the Q&A tab, if not, we will answer them orally at the end. So thanks very much for that, Dr. Mills.
You're welcome.
Very useful presentation. At this time, as Dr. Ananushu explained to us, these webinars could not be possible without our sponsors. And at this time, we want to have a sponsor presentation from Facey Pharmaceuticals. You may go ahead.
Good afternoon, everyone. Are you seeing my screen?
Yes, we are.
Okay, great.
Not in slideshow yet.
That's in slideshow. Good.
It's no, it's in slideshow. But it's at the last slide, so go back.
Okay, great. All right, so I'll be discussing today. I'll be presenting on Baralgin tablets, combination analgesic and antispodic use for the management of moderate to severe pain associated with smooth muscle spasm. So that is basically what Baralgin is. Where does Baralgin work, really? So Baralgin particularly is effective in areas where pain is caused by smooth muscles. For example, gastrointestinal spasm, which is typically present as a cramping pain in the mid-upper abdomen. The renal colic, which is felt as a severe flank pain due to the uteric or kidney spasm. Also, we will have dysmenorrhea in the lower abdomen as well. And you will have renal colic and biliary colic. The composition and mechanism of Baralgin includes metamizole, which is an analgesic, pentylphenone, which is a smooth muscle relaxant, and feniparinurbium, which is an anticholinergic drug as well. Clinically, the indication and clinical use for Baralgin includes renal colic, biliary colic, dysmenorrhea, gastrointestinal spasms, post-operative pain, and high fever. So the dosage for Baralgin and onset for adults, it's 500 to 100 milligrams. That's 1 to 2 tablets, 2 to 3 times daily. Maximum dose of 1,000 milligrams as a single dose, up to 4 times daily. Children years, 14 years and older, would be 18 to 60 milligram per kilogram as a single dose. It has a rapid onset and it is well absorbed in the GI tract. So possible side effects of Baralgin includes nausea, dizziness, dry mouth, rare hypersensitivity reaction, and for very rare cases, you have angulolysosis. right? And why do persons or doctors choose Baralgin? So the conventional analgesics relieve pain only, but Baralgin has a dual action which relieves pain and both pain and spasm, targets the source spasmodic pain, improves patient comfort. So it's a short presentation where Face is presenting. Pain is temporary, Baralgin is faster. Do you have any questions for me?
Thank you very much. That was short and sweet, and certainly Baralgin is one of our medications that we use in our armamentarium when we are dealing with pain. And I know that it is readily available. And would you say the price is competitive?
The price is very competitive. It is very competitive, very, very competitive. And doctors do know the prices are very competitive there in different pharmacies, and it is in all pharmacies island-wide.
Okay. Thank you ever so much for that, and thank you for the sponsorship of the webinar this afternoon.
You're most welcome. Enjoy it.
Thank you.
Okay.
All right, so at this time, we're going to move on to our second scientific presentation. So it gives me pleasure to introduce to you Dr. Christopher Daly. He completed his MBBS medical degree at the University of the West Indies, did postgraduate training in obstetrics and gynecology, and subsequent fellowship training in gynecological oncology, and he completed a clinical observership at the Royal Infirmary of Edinburgh. He is a member of the Caribbean Gynecological Cancer Society, fellow of the International Society of Gynecological Cancer, fellow of the American College of Obstetricians and Gynecologists, and he is dedicated to advancing medical academia through research, presentations, and he's also a university lecturer. At present, he is head of the Department of Obstetrics and Gynecology at the Falmouth Public General Hospital and specialist at the G West Medical and Surgical Center. It is my pleasure to introduce to you Dr. Daly, who will speak today on chronic pelvic pain. Dr. Daly, over to you.
Oh, okay, thank you very much for that kind introduction. And thank you for inviting me to speak as well. I'm hoping that perhaps I'll be able to be given the opportunity to meet all of you in person. And so we'll have a hybrid if hopefully in the future I am invited to present again. So let me try and share. Let me see.
Right, you're seeing your slides now.
Okay. All right, so just want to reassure the audience that this is going to be a very basic presentation. Basic in the sense that I firmly believe that 95% of the management of all the patients that I see is based upon approach and basic principles, really. I believe that the family practitioners are of utmost importance in that we are often the first point of contact and play a critical role in early identification and appropriate management. And so management is usually holistic. And of course, as you have seen from the previous presentations, it's often a multidisciplinary approach, especially in cases that are often complex with overlapping causes. So many patients may not only have one cause of the pelvic pain, but numerous causes as well, which may or may not be related. And so this highlights the need for comprehensive and patient-centered assessment. So when pelvic pain comes to mind, we speak of it in an acute or chronic nature. And of course, the causes are multifactorial, most commonly. In this context, gynae, but GI as previously presented, genitourinary and musculoskeletal, among others. And we look at performing a focus assessment based upon our evaluation of the patient and to request the appropriate investigations and subsequent management. So oftentimes when we speak of pelvic pain, there is no hard and fast rule as to what will be considered cutoff for acute or chronic. But for the purposes of this presentation, acute is really referred to mainly pain that occurs less than 3 months. And often chronic is pain that's often presented by the time the patient reaches to us greater than 6 months in nature. And many times, this pain may be cyclical in nature, meaning related to the menstrual cycle, or non-cyclical. And I think a reasonable and oversimplified way of looking at it, but very helpful in our approach, is this related to pregnancy, or is this not related to pregnancy? So most of the pain in our context of gynecologists would be, as I said, is it related to pregnancy or not? And often you will see whether we want to rule out ectopic pregnancies if the patient has a positive beta HCG. Although ectopic pregnancies are not that common, obviously it is a diagnosis that needs to be made in a timely fashion in order to assist with appropriate management versus a miscarriage or ovarian torsion. I will just highlight some of these main causes. So typically, let's say a 25-year-old woman presents with low abdominal pain, say a one-day history, with whoever PV spotted for more than a week. Our last LMP was 7 weeks ago. Of course, based upon our discussion, you'll have to ask, what is her differential diagnosis? Is she pregnant? Is she not? What's the first investigation that you would do? And what is your immediate concern? So, of course, a pregnancy test is of paramount importance. There is nothing that I can think of in gynecology, whether benign or malignant, that is of significant immediate threat to life in a patient with a gynecological diagnosis if she is not pregnant, and the contrary is true. So a pregnancy test is of paramount importance. I can't repeat that even further. Even in patients who say, even genuinely and sincerely, that they have never engaged in sexual activity. Vaginal bleeding is not the most, in the case of ectopic pregnancy, tends not to be the most prominent clinical presentation of ectopics. However, this symptom of bleeding tends to be more common in miscarriages, but the timelines are also very important as well. Miscarriages are often of a shorter duration. They present often within 24 hours. There is some subjective relief of pain in the passage of clots, and their abdomen tends not to be acute in nature. So ovarian torsion is also a relatively common presentation as well in severe abdominal pain. In this case, obviously, your pregnancy test may often be negative. But bear in mind that pregnant patients do present with non-pregnant symptoms. So you need to have a high index of suspicion for other causes and not assume that even if the patient is pregnant, that the source of the pain is due to the pregnancy itself. Again, there is no typical patient, but a patient with ovarian torsion often presents with sudden severe one-sided pain, and they may even present with GI symptoms, also as a factor of how severe the pain is. but the pain tends to be intermittent in nature. And in those situations in which there is relief of the pain, pain often goes away almost completely. And then they have pain again in almost a spasmodic nature. This is often due to the fact that this may be as a result of the torting and an untorting of the ovary. And so typically many times the patient may come referred to the accidental emergency, present there asymptomatic and sent home, and present again further with severe pain. It's very important then that we diagnose this very early because prolonged torsion can result in ischemia. And with resulting ischemia and prolonged ischemia of the structures, there may be loss of the gonads. And the dead tissue may also increase the patient's risk of having infection. So oftentimes, even among our specialists, we ask to do a pelvic ultrasound. But I must warn you about using an ultrasound in order to diagnose a torsion. But because there is a dual blood supply of the ovaries, quite often the Dopplers may actually be normal. But I'm confident if you have a clinical suspicion and a high index of suspicion, therefore, is needed in order to request, in order to bring forth the appropriate management. I think as family practitioners, especially if we're seeing patients as an outpatient, patient presenting with an acute abdomen is enough to require a referral to the appropriate institution. So pelvic inflammatory disease is a very common diagnosis that we ascribe to patients. It is almost a difficult diagnosis many times, whether intentionally or unintentionally, that we tend to ascribe to women when they present with pelvic pain and the pregnancy test is negative. Should this be the case? No. But clinically, there are several cues that may lend itself to suggest PID or pelvic inflammatory disease. So as we know, it's an ascending genital tract infection, and many of the culprits that are involved tend to be sexually transmitted. And there's a triad of signs and symptoms that we often use clinically in order to, that's suggestive of PID. The low abdominal pain tends to be bilateral, not unilateral, because if there's ascending infection, the ascending infection tends to affect both sides of the tubes and don't have an affinity to one side over the other. And with this tenderness, which is seen in the abdominal examination, you have an associated tenderness that you may feel in the bimanual pelvic exams. So that associated area in the neck and the abdomen, there's elicitation of similar pain when you do a vaginal exam. And patients tend to be exquisitely tender when you do flick the cervix or cervical motion. Have to bear in mind, though, that any patient who is having abdominal pain for any cause, especially if there's peritoneal irritation, will tend to be tender, even when you do check for CMT or adnexal. So it's very important not to still think broadly when you're assessing a patient for the cause of pelvic pain, whether it be acute or chronic. Of course, to give a history of a vaginal discharge, but often the history of vaginal discharge may not, well, it's very hard to delineate because many patients do have a physiological discharge and often it's hard to describe. While a patient by the time most patients with PIDs do not present with fever, well, that has been my experience, and it's not as common, except, however, in cases if the patient is having fever more than 101 with histories of rigors, for instance, then that patient tends to be very ill. And as you may imagine, this may often be confused with appendicitis. Of the two, appendicitis would be, of course, if suspected, a very important diagnosis to rule out. But what is markedly noted in patients who may present with severe PID in such a case, of which referral to a hospital setting and admission is required in the presence of fever, their symptoms tend to improve very quickly. So when given IV antibiotics, you notice that their symptoms tend to improve within the first 24 to 48 hours. So in the context of a patient who you have high clinical suspicion of PID, symptoms and physical examinations and initial investigation are suggestive of PID, but you notice that after a day or two that their symptoms are not improving, or from your usual cocktail of medications, quite often they like ceftriaxone, doxycycline, metronidazole after a 2-week period for the treatment, and their symptoms are not improving, then we really have to be suspicious that this may be something else that is presenting and paraded as PID when it isn't. Also, a very, very important thing is that even though I mentioned that the pain may be bilateral and low, if in the event, sometimes, of course, they may present with acute pain or chronic pain on one side, then if it is related to PID, then quite often they have a collection and they have to have a society index of suspicion for an abscess at such a moment. Forgive me, if you're hearing the noise in the background on a Sunday. So chronic pelvic pain tends to be persistent, and their non-cyclical pain may last, as I said, more than 6 months. And as you may imagine, this may have especially a significant impact on quality of the life, especially physical, emotional, social well-being, and may even create some amount of tension, especially as it affects our sexual function. And the etiology, of course, again, I can't emphasize this any further, that they may be multifactorial. And so we have already reiterated the importance of the family practitioner in navigating the space for the patient. And in cases where a diagnosis is often unsure, then to refer when appropriately. Even when patients are referred to myself or my colleagues, trying to delineate what's the cause of the pelvic pain is not an easy task. So we put it based upon our discussion so far. I mean, in a simple manner of, you can look at it anatomically if you wish as well. Just having a high index of suspicion again, and a great insight as we approach our patients that, a female who's presenting with pelvic pain may also have, as I said, GI causes as well, or it may be musculoskeletal, and there may be some amount of psychological component, not necessarily cause and effect, but as a result of bearing with this discomfort for such a long time. And so I came across this acronym that Are You Moving Some? And it seems very extensive. But this is just to bring home the point that there may be numerous and many causes of pelvic pain, and just a simple insight as to what direction that you're going to go based upon history and examination to rule it down into the basic differentials. And a safe and a reasonable approach would be, obviously, to rule out causes that pose an immediate threat to the life of the patient. And then once you have ruled out those causes, then it gives us time to offer the appropriate investigations to find out what the other differentials are, and to provide appropriate treatment, and to also refer appropriately as well. So a very good source, which I saw, is the International Pelvic Pain Society. They have a website as well, and we are aware of commonly, as we see through our assessment of pain, especially through med schools. We have used charts such as the pain scale of 1 to 10 as well. And there are many other examples, but this is the best one so far that I've seen that you could perhaps adopt for your practice. And so obviously your examination, the emphasis of your examination is going to be based upon what differentials you have narrowed down based upon the nature of the pain and the circumstance, the history in which the patient present. But just to show for an example, so a musculoskeletal pain may be noted, especially in the joints and the connection of the joints, if you do forced abduction, external rotation, or a Carnot sign, for instance, is a clinical test used to determine whether the abdominal pain originates from abdominal wall rather than internal organs. We can debate the sensitivity, of course, and specificity of such a test, but just to highlight the point that our indexes of suspicion can be further delineated by certain maneuvers. So simply eliciting contraction of the muscles of the abdominal wall may tune into disruptions or source likely to be focal in nature. If such a maneuver causes increase in pain in such an area, or if there's no increase in pain, then the source is more likely visceral. So from a gynae context, you may do primary diagnostic screening, and I've seen on the market many panels which are available for screening. You have to bear in mind, I mentioned this quickly, where we do these STI panels without fear of revealing exactly the sources, but many of us are very much aware, and they depend on PCRs for the testing of the urine. Many of the culprits that causes severe pain for PID from STI, like gonococcal or chlamydial infection, are very hard or fastidious in nature, meaning they're very hard to grow in a lab. And quite often you may even require endocervical swab in order to do so. And in any event, it all depends also on the timing, the preparation of the swab, how the swab was performed as well. So a negative test does not necessarily rule out the presence of infection. So it's just to bear that in the mind. No, use of transvaginal ultrasounds, very good at identifying masses. And in fact, in expert hands, they may be comparable to MRI, but of course, MRI is not as readily available. MRI is very expensive, especially to most. And but where a mass is found, MRI is often or very superior to that of the CT scan in delineating the nature of the mass, the borders of the mass, and its relation to surrounding structures. So further to an ultrasound, if you want to garner more information as to what's happening in the pelvis, then MRI is a better choice rather than a CT scan. CT scan is not very good in looking at pelvic structures, presumably also because of what's there protecting the pelvis, which is the pelvic bone. So MRI is very good at, ultrasound is very good at imaging for adenomyosis, for example, which is a spin-off from endometriosis. And we're sure that the sensitivity and specificity are comparable for either. So quite often from a gynae point of view, one of the most common diagnoses that patient may be ascribed to is that of endometriosis. And again, this is pain that is often associated with the menses, and it's quite characteristic. This pain tends to occur before there's physical presence of bleeding, and they may often progress even after as well. There are some clinical cues as well, as it may be related to endometriosis. And again, I don't want to delve into too much detail because endometriosis in and of itself is an entire presentation on it. But if a patient gets a trial of medication that helps to suppress, based on its physiology, helps to suppress the menstruation, and you find that there is an improvement, then pain associated with things such as endometriosis may be highly suspected. And so you have hormonal trial, and I do advise this prior to any surgical intervention. And if there's no improvement, then diagnostic laparoscopy is definitely a tool which is very helpful. By the time the patient is being investigated and worked up for diagnostic laparoscopy, I presume then this is a patient that you would have already referred before. But it is also important then, therefore, that even patients that I see and are referred to me, that when I counsel these patients, they quite often go back to their family practitioner and ask questions about what has been said, which is normal and which is helpful as well to verify the information. And many times counseling, being a very most important part in seeing the patient, is very difficult to do in one setting. And so it's just to bear all of this in mind, and again, emphasize the fact that we then integrate with multidisciplinary care and investigations that you find that may be helpful, as presented in the previous presenter, that patient may be due for screening, such as colonoscopy, for instance, that may also help in the armamentarium of information to help you to know what's going on with the patient would be encouraged as well. And so just quickly to mention, there's a lot now that has been spoke about in conventional and non-conventional medicine. Patients read, patients see a lot on social media, and there is an advent, having ruled out any sinister causes, the use of pelvic floor physiotherapy, for instance, where there is myofascial release or electrical stimulation and biofeedback occurs, and cognitive behavioral therapy with thought modulation in someone who's been suffering with this inconvenience and coping mechanism. And of course, sexual therapy, with often chronic pain may cause sexual disorder. And quite often, the discussion of sex is often pinpointing to whether or not there is impotence, male impotence or not. And it goes much broader. And we have to really tackle that and understand that, many times you may have orgasmic disorders and dyspareunia and affection, and which may directly or indirectly affect affection and partner dynamics as well. Of which there are specialists who are well equipped into dealing with each of these facets of treatment as well. So when you're dealing with specialized pain treatment now, as it relates to pelvic pain, you may even go as further to speak about or counsel about laparoscopic presacral neurectomy, especially uterosacral nerve ablation. So studies are still ongoing as to, in terms of the long-term effects and benefits of such treatment, but they're there and they're present, and trigger point injections. And of course, the holistic approach in terms of appropriately counseling or getting advice as it relates to alternative integrated medicine, which from our culture, I find that our patients may actually feel more accommodative of these, such as acupuncture and yoga. And so you look at biologically based compounds or synergy between the mind, body, and bioenergetic points. So selective norepinephrine reuptake inhibitors, well, effects. The benefits of these are a bit varied, and depending on the source that you get, you have really varied effects that may or may not improve. But especially though in patients with neuropathic pain, we can extrapolate from their benefits in other conditions, that we may actually see some benefits in those that affect patients in the pelvis and the pelvic floor. And of course, through our sponsors, we mentioned the use of muscle relaxants, that their benefits have been described. But one of the biggest points that we can see from all of this, the use of these medications, is that opioids is not recommended by most international bodies and guidelines. Primarily so because chronic pelvic pains tend to occur for a very long time, and the primary diagnosis or underlying cause can often be elusive, and so it lends itself to dependence, and so we want to try and avoid the use of opioids in treatment of such patients to subsequently avoid the likelihood of adverse effects. So really, the key takeaways from this presentation is that, at least from a gynecological standpoint, that you start off always ruling out pregnancy, especially in patients who insist that they are not pregnant. It's of paramount importance and very important for you to understand it, especially in an acute setting, how urgent you're going to approach this patient, and how you're going to refer where and how quickly you want to refer the patient, how much time you have in investigating the patient appropriately. And the second point is I want to ensure that you think broadly as well, as you've seen that not every female who presents with pelvic pain when they're pregnant is an ectopic, or not every patient who's not pregnant is a PID. And you have to also bear in mind that pregnant patients do have non-gynae causes of pelvic pain. So we tend to see only what we're looking for. And so really, again, I use the term, if I'm counting at least 4 or 5 times in this presentation, you need to have a high index of suspicion. And of course, you look for, in so doing, you see red flags that will help you to decide who is most urgent, who needs to be dealt with now, as opposed to who do we send to do investigations, or who do we send to do a trial of treatment and follow up in the next couple of weeks. And of course, we escalate early if we are unsure. And again, there's no shame in not being sure, because to be honest, if I were to be completely honest with you, that aside from the obvious anatomical causes, meaning that you have a space-occupying lesion that is present in the pelvis, more than half the time, the cause of pelvic pain, especially chronic pelvic pain, even to a specialist, is the diagnosis and underlying cause is often very elusive. And so it can be quite frustrating, not only to the patient who look into us for treatment that you can sign and prescribe, but also to us as a caregiver, where we get a lot of pressure in delivering and causing some such patients. All right.
Thank you so much, Dr. Daly, for that very interesting, informative presentation. You reminded us that we always have to think broadly, but when it comes to pelvic pain, but that you then took us through some of the important differentiating signs and symptoms for common gynecological causes of pelvic pain. You reminded us always to rule out pregnancy, and then to rule out things that could be life-threatening, like your ectopic pregnancy and appendicitis. You gave us a number of useful mnemonics, which we can look up, charts and signs that we can use as we are going through this issue of pelvic pain. There are some questions I know in the Q&A that Dr. Mills has been answering. If there are any questions for Dr. Daly, please put them into the Q&A tab, and I'd ask you, Dr. Daly, to take a look, even though we will have a short session later when you can answer some of them orally as well. So once again, thanks very much for that very engaging presentation.
And thank you once again for having me.
As we move forward, we have two of our sponsors who are going to present. First of all, Health 2000 H2K, and then Servicare Distributors Limited. So I'm going to hand over at this time to Health 2000. Mr. Heron, do you have something from Health 2000? Or is a rep here with us?
Hi, Doc. No, we don't have anything from Health 2000.
Is anybody here from Health 2000?
No.
If not, you don't see anybody?
No,
All
no,
right.
no. There's no.
We would like to thank them very much for their contribution to this webinar, and look forward to hearing from them at another time. Is anyone here from Servicare Distributors Limited?
Yes. No one from Servicare, Lynn?
All right. If those persons are not present, we can move ahead.
Sure.
We could probably have one of the ones of the sponsors from later on. If anyone is here from Indus Life Science.
Mr. Dayanan should be here.
Yes, let us have Indus Life Science at this time.
Sure. Mr. Daya, are you there?
I think I see him.
Yes.
Maybe is he ready?
I'm not sure. Let's go to our sponsor, Viatris.
Good evening, everyone. I am Odin Foster, medical representative here at Viatris, and thank you for joining. Now, what patients desire most from pain management are reliable relief, fast action, and lasting results. With Celebrex, we can see how effective pain control can help patients to move with confidence, strength, and speed, getting back to their daily lives in as little as 22 minutes with sustained 24 hours relief. Celebrex is a potent analgesic and anti-inflammatory in both acute and chronic pain. In ankle sprain, patients treated with Celebrex experienced a significant reduction on weight bearing from baseline to day 3 compared to non-selective NSAIDs. In osteoarthritis, Celebrex showed similar efficacy with just a single 200 mg dose as ibuprofen at 800 mg 3 times daily. In terms of safety, Celebrex does not inhibit platelet aggregation involved in wound healing and interruption of ecchymosis that occurs with grade 2 ankle sprains. So therefore, if a patient needs to have surgery the same day, they can. Based on the post-hoc analysis of a precision study, unlike the non-selective NSAIDs shown, Celebrex showed a superior blood pressure safety profile with significantly lower incidence. Celebrex also showed a lower incidence of arterial hypertension over 12 weeks compared to non-selective NSAIDs and even compared to another COX-2. In fact, no meaningful change in systolic blood pressure was observed in the Celebrex group as seen in the graph. So what Celebrex offers is a balance between efficacy and safety. It offers rapid onset of action, significant pain relief in both acute and chronic pain, and prolonged pain relief. In terms of safety, Celebrex is the only FDA-approved COX-2 in the US. That's primarily because of its proven GI and cardiovascular safety versus numerous traditional NSAIDs. Celebrex also is not contraindicated in patients with hypertension. Just to remind you of the dosing, for acute pain, it's 400 milligrams loading dose and 200 12 hours after if necessary, and then 200 milligrams once or twice daily on subsequent days. For chronic pain, it's 200 milligrams once or twice daily, depending on patient response. So Celebrex has flexible dosing. While Celebrex speaks to inflammatory pain, when neuropathic pain enters the conversation, Lyrica finishes the story. Neuropathic pain is generally associated with comorbidities that can affect how the patient experiences pain. About 50% of patients with neuropathic pain experiences sleep disorders, and about 60% experiences anxiety. Now, in combination with the pain, the patients experience a reduced quality of life and functionality. Lyrica helps in the treatment of all the elements of the pain triad to improve the results of the patient. So less anxiety, less pain, less sleep disorders, more quality of life and functionality. And just to note, Lyrica actually has first-line indication for the treatment and management of generalized anxiety disorder. And Lyrica is associated with fast and significant reduction of pain at the very first week. 150 to 600 milligrams per day may be given in either 2 or 3 divided doses. The dose can be increased according to the patient's response and tolerability. Recommended start dose 75 milligrams twice daily, and after 3 to 7 days this may be increased to 150 milligrams 2 times daily. As it relates to migraine, consider triptans as first line when simple analgesics have previously failed. Relpax is a part of the stepwise approach for acute migraine treatment, as per the guidelines. Based on results from a meta-analysis of 74 clinical trials, Relpax had the highest probability of achieving pain-free response and headache response among oral triptans, as it demonstrated superior efficacy at 2 and 24 hours among these oral triptans. Relpax was the most effective oral medication in achieving pain freedom at 2 hours, even compared to some of its main competitors. Relpax is available in a 40 milligrams tablet. The maximum single dose is 80 milligrams. Relpax should be taken as early as possible after the onset of the migraine, and a second dose may be administered at least 2 hours after the first dose. No more than 80 milligrams should be given within a 24-hour period. That's the end of the presentation. Thanks for listening.
And thanks very much. That was a presentation from Beatrix, and I'm sure that we are all familiar with some of those medications and also use them in our day-to-day practice. At this time, we are going to go ahead to our... Oh, Mr. Okay, Indus is...
Not it. I'm just waiting.
Yes, you can go ahead. You can go ahead.
Yeah, I'm available. I'm just on the Zoom.
Are you ready to go ahead now, or are you after the next speaker?
Good afternoon.
Afternoon.
Doctor, is it my presentation now?
Yes, you can.
Thank you. Let me share my screen. Hope my screen is visible.
Yes, it is.
Thank you, sir. Okay, wishing you all Happy New Year once again from Indus Life Sciences, as this is more of pain-related topic like abdominal pain and muscular pain. We have a couple of medications which is ideal for those indications. So just like to refresh them today. And of course, before starting, we know we all had a hard time in last year, October. So a couple of our parishes already badly damaged. And as a company, we have a lot of responsibility to support those communities. We reached many communities, especially in St. Elizabeth, Westmoreland, St. James, as well as we reached out to Falmouth, and we distributed a lot of medication, and we continue to do so till these communities get back to normalcy. So we stand with those communities. And just for the persons who suffer from hyperacidity, heartburn, gastritis, flatulence, acid reflux, and ulcer, we have one of the beautiful antacid from Indus Life Sciences, which is available currently across Caribbean. Even though you could see in the screen as first time in Jamaica, but honestly it is first time in Caribbean because I happen to travel most of the Caribbean countries, right from Cayman, Bahamas, Turks and Caicos, as well as Guyana, Barbados, Belize. I never seen a combination of such a wonderful antacid like New Gel. The uniqueness of this antacid is that it has this alginic acid benefit, which many times I also presented. It's basically an algae which forms a foam, as you could see in the screen, a raft when the person takes the antacid, and it acts like a barrier, stopping the stomach content moving from stomach into the food pipe, which is basically GERD. When it moves from the stomach content, which is acidic in nature, moves from stomach into the food pipe, esophagus, it causes a burning sensation. So many times we experience this when we eat our favorite food, belly full, and then we lie down. It happens. So sometimes at bedtime, if it happens, it disturbs the sleep. So we have this antacid which can stop that. And to understand it better, a small clip is here that could basically explain how it works. Now the person has taken the new gel, and the alginic acid in the new gel now interacts with stomach acid. As you could see here, the foam is formed in just 4 minutes. And this foam blocks the stomach content moving from stomach into the food pipe. So this action actually continues literally almost for 5 hours. And after 5 hours, the alginic raft that is formed by the alginic acid in new gel is get excreted completely. That means after 5 hours, the person is ready for the next meal. So they can take it if they have the experience the GERD condition. And obviously, new gel has regular antacid medications like aluminum hydroxide, magnesium trisilicate with neutralized acetate. Dimethicone, you could see here, that relieves gas. Is sugar-free antacid, safe in diabetes. That means also safe in pregnancy, even first, second, and trimester it can be recommended. It's a mint flavored antacid. Mint, promotes digestion. The extension of Nugel is there, which is basically the unique of its kind, the game-changing antacid in Caribbean, which has the pain medication oxytocin, which actions similar like lidocaine. Oxytocin is a mucoso anesthetic medication, which gives a coating to the stomach wall. Thereby, gastritis pain, acidity pain, ulcer pain will be relieved instantly with a Nugel O. Nugel is safe in pregnancy, but Nugel O is not recommended in pregnancy, even though both of them over the counter. Nugel O will be dispensed by the pharmacist. And the Nugel O is not recommended less than 12 years, but Nugel can be given as young as less than 10 years of age. Unusual also available in sachets. The first time again, we are the first company to introduce on-the-go sachets. It's available in all the pharmacies. Each strip, as you could see in the picture, one sachet has got 10 ml liquid inside. No need to dilute with water. Just stir it and drink it straight. Very convenient for those who travel a lot. Instead of carrying the bottle, you can just sachets with you. And a small.
I told you, gel relieves heartburn. Oh, we need food and some good wine. Good thing new gel antacid relief lasts longer than that late night snack. New gel relieves acidity in as little as 5 minutes. Give me new gel antacid. Quick and fast. New gel antacid is sugar-free, safe for all, and the only antacid with liquid on-the-go sachets. New gel antacid. Quick and fast, relief that lasts.
Trust me, it's really quick and fast. And we have Capsitop. You all know about this. The combination of capsaicin, diclofenac, methyl salicylate, and joint pain, back pain, shoulder pain, knee pain, all pain almost, except heart pain, any pain it can be recommended, is over the counter. And we have the pain spray, which is also doing extremely well, getting very positive review. This is organic pain spray. I mean organic in the sense all plant extracts it has eucalyptus, turpentine, methyl salicylate, menthol. And it comes as 43 ml small container, which is just priced less than 400 Jamaican dollars. And the bigger version, 150 ml, is priced around $800. And the 43 ml is very convenient for those who travel. You can carry it in your handbag, not even in your check-in bag. Ready spray, can keep it in a first aid kit, all those things. That's a Ready spray. We're getting amazing response for Ready spray. It's over the counter again. We have this nice tagline, which just like KFC, we also coined it: powerful like a real beer, safe like a teddy bear, because of all natural. The last brand which I like to remind you of pregabalin, neurobalin. Good news is that in the month of November 2025, just a couple of months ago, we slashed down the price, as you could see here in the screen, subsidized by NHF 100% now, because this is the most affordable pregabalin. Our price is just $2,075, which is a month supply. So currently, the most affordable, if you want to help your patient, because this is a chronic medication too. Many times patient takes this for lifelong too. So you can imagine a drug like pregabalin is available at this price because we have slashed down the price. And please remember to write it as neurobalin to help your patient to get this benefit of price reduction. That's our neurobalin. Of course, our 150 is also subsidized 100% by NHF. That's our neurobalin is our pregabalin. Thank you very much, and please remember amino Pt2. Thank you, and enjoy the rest of the presentation. Bye.
Thank you so much. India's always one of our consistent supporters. We appreciate your support, and certainly your medication line is well known to us and well used by GPs across the island. So thanks very much for your continued support.
Thank you, Doctor.
We are now going to move on to our third scientific presentation. And it gives me great pleasure to introduce to you Dr. Jordan Eaton, a graduate of Campion College, who matriculated to study medicine at the University of the West Indies, Mona, where he finished in 2014. He completed his junior and senior house officer years with the University Hospital of the West Indies and the Kingston and St. Andrew Health Department before working as a medical officer in psychiatry at the Kingston Public Hospital, treating psychiatric patients on open general medical wards. He subsequently returned to the UWI for the DM in psychiatry, which he completed in 2023. His DM project on patterns of referral to the consultation liaison psychiatry service at UHWI was awarded Best Overall, Best Student, and Most Impactful Poster Presentation at the National Health Research Conference in 2023. He has also helped to write several papers on psychedelic mushrooms in treating medical health conditions in Jamaica, and currently works as Senior Registrar in Psychiatry for the Spanish Town Hospital and with the St. Catherine Health Department. Please welcome Dr. Eaton, who is going to speak to us on psychological dimensions of pain. Dr. Eaton, over to you.
Hi, good afternoon, everyone. Just a quick mic check to hear that everyone can hear and see the presentation, okay?
Absolutely.
Fantastic. So thank you so much, CCFP. Today we're going to be talking about the psychological dimensions of pain, why it still hurts, the brain, behavior, and chronic pain. So, outline, plan of action, the narrative of pain, the neurobiology of pain, the role of the psyche. Common things are common, pain and the non-psychiatrist, the role of the non-psychiatrist, and finally, the psychiatrist and the non-psychiatrist. Now, we are at slide 3. I apologize in advance. I may speak quickly, I may speak slowly. We will see how that goes. I did take my medication this morning, so that's a good sign for us. There are 50 slides in this presentation, so you can get an idea of where we are just by checking the slide count at the bottom. We're just going to have some fun. We're going to keep it nice and simple, and we're just going to tell a story because this is applicable to everybody. And we all know persons living with pain, and we all know what it is personally like to be with pain. So let us explore it a little bit more. So, the narrative of pain, because all pain tells a story. Pain itself, an unpleasant sensory or emotional experience associated with actual or potential tissue damage, or described in terms of such damage. It's a sensation of the body. It is always unpleasant as an emotional experience. Patients with a long history of pain disorders have increased depression and anxiety symptoms, as well as suicidal thoughts. Patients with more severe depression and anxiety symptoms also have an increase in pain problems, and we're going to touch on that in a second. Looking at pain by the numbers, chronic pain, that is pain lasting for 3 months or longer, for adults in the US, it's been linked with depression, Alzheimer's disease and related dementias, a higher suicide risk, substance use, and misuse. 1 in 20 adults in the US, which is approximately 12 million people or 5%, are living with chronic pain. 55.6% of adults with chronic pain reported unremitting depression and anxiety versus 17.1% who didn't. So those who have more pain have more depression and anxiety. Almost 70% of adults had work limitations, whether it be from the pain, the depression, or the anxiety. Almost 44% had problems doing errands alone, and almost 56% had problems participating in social activities. And this is just looking between 2019 and 2021. Pain has zero regard. In 2021, 6.9% of adults in the US reported high impact chronic pain. Prevalence is increased from age, with 12.3% between the ages of 18 and 29 to 36% in the ages 65 and over. Rates are higher in women, rural residents, veterans, and individuals with lower socioeconomic status. And chronic pain affects roughly 20% of the population worldwide. So that's 1 in 5. Over 55% of adults with chronic pain may also experience symptoms of anxiety and depression. So, contextualizing, if 1 in 5 persons on the planet is going to experience chronic pain, of those 1 in 5, it's a 50-50 chance almost that these persons are going to be having symptoms of depression and anxiety. So these phenomena are inextricably linked. The question is how? So we have to understand the brain and the pain. And I apologize in advance because we have to do neurology things very, very quickly. And I know this is usually a problem for people, but we're going to keep it very, very simple. We are looking specifically at the areas of the brain associated with the sensation and perception of pain. First area we're looking at is the prefrontal cortex. Where is that? Right there. It's the forefront of the brain, just behind the forehead bone. Executive function, it encodes the cognitive aspects of pain, the meaning of pain, and how we deal with it. The next area is the anterior cingulate cortex, the ACC. It's a part of the limbic system. And this is associated with fear memory acquisition. The limbic system is one of the most primitive parts of the brain. It is one of the most primal parts of the brain. And it is associated with, as you see, fear, anxiety, fight, flight, survival instincts. The affective and emotional component of pain and suffering is associated with the ACC. And it is just behind the prefrontal cortex. Next areas that we need to recognize are the primary and secondary sensory cortex, otherwise called S1 and S2. Where are they? Right there. So about the mid of the brain, bilaterally. They help to identify where damage has been or may have been. And S2, which is the section slightly posterior, is associated, well, posterior and inferior, is associated more with encoding the severity and the quality of the pain. Finally, we have to look at the insula. This, again, is another part of the limbic system. It is responsible for physical condition versus motivation. So the concept of feeling hunger or thirst versus satisfied and physically content. So again, a very primitive sensory experience that we're looking at. And it can't really be seen from the external aspect. It has to be a sagittal because it's a deep brain structure that's usually sandwiched with by the outer folds of the brain. So why do we need to know about that? No pain center is in the brain. Pain is perceived through the integrated cortical system and relived when systems are disengaged or disrupted. Chronic pain has ongoing input from peripheral nerves, which can produce brain changes. It can sensitize areas to become more active in response to future pain signals, for example. Chronic pain conditions have also been associated with change in the cortical organization as well as the cortical volume, meaning you are changing how the cells are organized and you're changing the sheer number of cells that you're having in the brain. Chronic back pain or fibromyalgia is associated with decreased gray matter in the prefrontal cortex area, which is associated with the decreased ability to inhibit the experience of pain. So, yes, there may be organic causes However, there is the interplay between these sensations and the neural tissue of the brain itself on the experience itself of pain. So, in talking about the psychological and the neural mechanism, there is an affective dimension of pain, the feelings of unpleasantness and the emotions associated with the future implications. We sometimes call this a secondary effect of pain. Studies show serial interactions between pain in sensation intensity, pain unpleasantness, and the secondary affect. It relates to a central network of brain structures that processes nociceptive information both in parallel and in series. So, spinal pathways to the limbic system and the medium thalamic nuclei provide direct inputs to brain areas involved with the affect. So, what we're seeing here is that you are tying in all of these different areas, both in terms of physiologically and psychologically, and they're integrating in the brain through this pain experience. Another source can also be from spinal pathways to somatosensory, thalamic, and cortical areas, and then through the cortical limbic pathway. So again, the thalamus, where most of these signals are going to go, is the great way station of the brain. This is where signals are transmitted everywhere else. So you can see the great interconnectedness of the physiological and the psychological and how it's going to come into play. So secondary pain affect, it involves meanings such as perceived influence with one's life, difficulties of enduring pain over time, and the implications for the future. So this is what you are seeing to come as a result. Pain is often experienced not only as a threat to the present state of one's body, comfort, or activity, but also one's future well-being and life in general. So contextualizing, the secondary pain is going to be the futurization. Yes, I am experiencing chronic pain now, but then the secondary effects of me thinking about my life with my experiences to come, living with continued chronic pain. So the million-dollar question becomes, what's the role of the psyche beyond just the neurophysiology of it all? Severity is subjective, and we know this. That's why we have a pain scale. The cortex of our brain gives meaning and interpretation of the pain. The limbic system, such as the anterior cingulate cortex and the insula, are associated with emotion and threat of pain. You have the central sensitization, i.e., the more this experience happens, the more likely the brain is to respond to it, and the brain is preparing to respond to it. What this means, as we all know, imaging does not equal pain level. Two patients with the same injury can experience different levels of pain because beyond the physiological, there is the psychological. Pain sensation and pain unpleasantness are two distinct dimensions of pain and are separately influenced by psychological factors. So we need to speak about the bidirectional relationship. Chronic pain causes stress. Sleeping problems reduce socialization. This can lead to depression and anxiety. The problem is the depression and anxiety can lead to increased pain severity, increased pain sensitivity because of the stress pathways that are being involved vis-a-vis corticosteroids, as well as the changes on neurotransmitters within the brain. The prevalence of physical and somatic symptoms existing concurrently in patients with major depression in tertiary care ranges from 30 to 54%. So again, we should be seeing quite a lot of this. The question is, are we recognizing it? And that's why we're here today. Studies have reported that depression is not assessed in up to half the patients experiencing physical symptoms, thereby increasing the risk of these patients developing more severe depression and greater treatment resistance. And again, the knock-on effect of a higher sensitivity to pain and a higher subjective intensity of their pain. There is a shared biology. Chronic pain and mood disorders share underlying neurobiological mechanisms, including similar neuroplastic changes. There's a heightened risk. Individuals with chronic pain are 4 times more likely to experience depression or anxiety compared to those without pain. And the impact of high impact pain. This is persistent disabling pain often leading to higher rates of suicide, social isolation, and cognitive impairment. So, in understanding the psychology of pain, we have to consider the psychological dimensions. There is the cognitive evaluative component of the brain, i.e., thoughts and beliefs. There's the motivational or affective component, i.e., the emotions and feelings. And there is the interplay between those thoughts and those affective symptoms or affective conditions and the subsequent behavioral or action dimensions. So, cognitive evaluations. Thoughts and belief, how individuals interpret, appraise, and understand their pain. Pain catastrophizing, a negative, distorted perspective focusing on the helplessness, hopelessness, and severity of the pain. Beliefs and expectations, previous experiences and knowledge about pain influences current perception. And attention, focusing on the pain can amplify it, while distraction can reduce the pain. So these are the way that the cognitive aspects of pain can manifest within the psyche. The motivational / affective component in terms of emotions and feelings, emotional subjective response to pain, often driving the behaviors that follow. So there is emotional distress. Fear, anxiety, anger, and depression are common, especially in chronic pain. Suffering, its subjective emotional reaction to pain, which is distinct from the physical sensation itself. Finally, we discuss the behavioral dimensions, actions and responses. So we're talking about fear or fear avoidance. Avoidance or fear avoidance. Avoiding actions, activities, anything due to fear of pain, which can lead to physical degradation and increased distress. We also have to talk about coping mechanisms. So active strategies such as staying active and passive strategies such as waiting for treatment, resting, and it can have an impact on the functional outcomes. We also need to consider work, compensation, litigation. There is a higher reported pain intensity, slower recovery, and it's not necessarily a conscious exaggeration. There can also be the familial component where attention of pain behaviors is played into, or there is relief from patient responsibilities, or general family overprotection. What is important to recognize is that in spite of these social factors, and in spite of everything that we have discussed up to this point, whatever factors that this person is exhibiting, it does not mean that the pain is fake. That's our take-home message. So let's kind of put things in perspective. Pain is not just nociceptive. The mood influences pain perception. Anxiety alters threat processing. Cognitions shape our interpretation, and the trauma sensitizes the nervous system. Sleep and coping modify the outcomes, and finally, the social context shapes our experience. Pain is beyond just the physical. We have to consider everything. We have to consider the bidirectional relationship. With depression and pain, you have a lower pain threshold and reduced descending inhibition through the spinal cord. Poor sleep worsens pain, and low motivation leads to eventual deconditioning. So people will just stop. You also have anxiety and hypervigilance, the autonomic arousal and heightened threat perception, the increased attention to bodily sensation, the fear of movement, and the reassurance-seeking behaviors. And for those of us who have seen patients in chronic pain, if we stop and reflect, I'm sure most of us have seen something to this effect in at least one person. You also have the pain and fear cycle. Fear leads to avoidance. Avoidance leads to deconditioning. Deconditioning leads to more pain. More pain leads to disability. And we see this in lower back pain and postoperative recovery. Another psychological component of the pain, catastrophizing. This is unbearable. I can't stop thinking about it. Nothing will help. These things are strong predictors of postoperative pain, and they are associated with pain chronicity. You have increased amygdala activation when trauma enters the mix. There's reduced cortical inhibition. There's persistent sympathetic arousal. There's distress during procedures, and there's avoidance of healthcare settings. Hyperarousal mistaken for exaggeration. That's the effect of trauma. Again, sleep, bidirectional relationship. A lack of sleep increases your inflammation, impairs your regulation, and improving sleep reduces pain intensity. Family reinforcements, the workplace stress, the compensation and litigation complex, the identity disruption, and the pain behavior that is socially shaped. So, we need to consider common pain presentations with strong psychological components. Common causes of chronic pain: chronic lower back pain, fibromyalgia or widespread pain, postoperative pain that's persisting, neuropathic pain. A lot of us are going to see the patients with diabetes mellitus, the neural damage or the allodynia, all of these things that we have to consider, as well as functional pain symptoms. The flags that suggest that there's psychological amplification. The pain is disproportionate to the findings. There is poor response to escalating painkillers, multiple prior interventions, and there's a high distress level as well as sleep disturbance. Let's focus on why we're here. Where does the non-psychiatrist fall into this equation? The general physician and pain is very interesting because in 10 minutes you can ask so many questions and you can help so many people. It's just about knowing the questions to ask. So we can start with simple ones. How is pain affecting your mood or your sleep? How has the pain been making you feel? Yes, people are going to state the obvious, but it's a start in the conversation because that's how we begin to make an assessment. What worries you most about the pain? Have you noticed that it makes it better or worse? What are you afraid of happening if this continues? Sorry, what will you be afraid will happen if this continues? So, simple questions that can help to start a conversation and can help us to contextualize pain from a non-specialist, everyday, holistic approach that people still seek for, which is why we still have so many general practitioners. And that's why we trust our GPs, because they know us better sometimes than we know ourselves. So we can do our patients a favor. The do's and don'ts. Language to avoid: nothing is wrong. It's all in your head. It disregards this person's lived experience. Pain is subjective, and you are completely disregarding their subjective lived experience when you say things like this. Things you can say: pain is processed by the nervous system. Your brain and body might be amplifying the signals. It lets this person know that there is a connection between what they are feeling and what they are feeling, meaning physical and psychological, the interplay between the two. And sometimes that can be the start to help people feel like they're not just making this up or they're not just losing their minds. Simple things to do. Education. We can reframe pain without invalidating it. We can, for example, explain the central sensitization phenomenon, meaning with these persistent pain signals, and we're not addressing the emotional components of it, it raises the susceptibility or the sensitivity or the intensity of the pain that we are already experiencing as a result of these neural processes. We also have the issue of multimodal treatment. Medications have a role. Physiotherapy and pacing do have a role. And there are psychological interventions, as our first two presenters did mention. CBT, cognitive behavioral therapy, is still one of the mainstays. There's also ACT, acceptance and commitment therapy. And we also have pain psychology. So we have options. It's just about figuring out what is going to best help our patients. Easy things are easy. So what do we not do? We don't escalate opioids indefinitely, because then we are running the risk of substance misuse. We don't do repeated procedures without reassessment, and we never dismiss our patient's symptoms. And one of the other easy things that we can do is we can screen. And for those of you who have heard me speak before, I apologize, but you're going to get sick and tired of it. The Pt2, the GAD7 screening tool for depression and anxiety. It is tried, it is true, it is reliable, it is easy to administer. And again, it spits out a number at the end that can correlate to a symptom severity that will suggest, hey, we should probably get someone involved very quickly, or maybe this is something that doesn't need urgent referral or doesn't need medication and can respond to talk therapy. Again, only 2 options, the Becks, the Hamiltons, so many. You want to be more detailed in the Pt2, you can go to the Pt15 if you want. Want to be less detailed, go to the Pt2. Options exist. The psychiatrist and the non-psychiatrist, because we need to start collaborating more. When it's time to refer patients to the psychiatrist is when we have comorbid depression and anxiety. When there is suicidal ideation linked to the pain. When there is significant functional impairment, or when there have been repeated interventions that have been unsuccessful. And the trick always comes down to how we frame the narrative, because we can be honest. No one ever really wants to go to a psychiatrist, but no one ever wants to ask the question that a psychiatrist needs to ask. So how are we going to meet in the middle? If you say I'm referring you to a psychiatrist, that may go down poorly. But if you frame the narrative, this is part of a comprehensive pain plan. Specialists in how the pain affects the brain. It's not a last resort. There are other interventions. This is the multidisciplinary approach. It changes the narrative and it can make an otherwise potentially hostile situation de-escalate. Why the non-psychiatrist? Patients are being managed by their managing doctor or a team. No one wants to talk to me. I know this very well. Starting the conversation with the primary care providers helps to normalize things. Compare sending a patient to a psychiatrist without any real reasoning or conversation versus having that conversation and explaining why. It will make a difference. Other interventions that we can consider, supportive psychotherapy. And to be very clear, supportive psychotherapy is one of the easiest forms of psychotherapy because it involves just acknowledging the patient's existence and what they're going through and helping them to recognize that even if it's not okay, that is okay. Anyone can do supportive psychotherapy once they mind the rules of not minimizing, not dismissing, and not using language to invalidate someone's experience. We can also have initiation or management of underlying depression or anxiety symptoms. Yes, as I said before, medication helps. Some can directly impact pain. Dr. Daly had mentioned before SNRIs, specifically 3 that we have in Jamaica. Venlafaxine, which is Effexor, desvenlafaxine, which is Prestique, and we used to have a third, which is Cymbalta, duloxetine, but unfortunately it has been discontinued from the market. Notwithstanding, we still have other options. Amitriptyline, for example, tricyclic antidepressant, it does help with neuropathic pain. Depression and anxiety from pain can still be treated with a regular SSRI medication, just like regular depression and anxiety. And what we know is because we are controlling the depression and anxiety symptoms, we can down-regulate the amount of pain signals that the brain is being sensitized for, help to relieve the psychological component, and thereby hopefully improve the physical component and this patient's pain level that they're experiencing. Shall we wrap up? Because I feel like I've been talking for far too long and I've only got a couple slides left, so just bear with me. It's never just pain. Pain is biopsychosocial experience. It's not just tissue damage. Mood, anxiety, sleep, trauma, and coping styles influence pain intensity and recovery from pain. Psychological factors modulate real pain signals. Untreated depression and anxiety worsen surgical outcomes and rehabilitation outcomes. And the psychology of it, depression, lower pain threshold, poor motivation, worse outcomes. Anxiety, hypervigilance, fear avoidance behavior. We can have psychological things, catastrophization, which is magnifying, ruminating, and leading to helplessness about the pain. Sleep disturbances generally increase inflammation and pain sensitivity, and sleep disturbances also lead to emotional dysregulation. If there's a specific trauma history, the nervous system is going to be doubly sensitized. So here are some pearls. If the pain improves when the mood improves, pain is modulated by mood. Avoid saying things like, nothing is wrong. Use, pain is processed by the nervous system and many things affect it or influence it. Escalating opioids without addressing psychology increases the chronicity risk. Early MDT management improves outcomes. And if you have 10 minutes and there are 10 things that you want to assess, here we go. Number 1, confirm biomedical assessment. Rule out red flags and surgical complications. Number 2, assess function. What is this patient unable to do? Number 3, screen for mood. How has the pain been affecting your mood and your sleep? Number 4, screen for anxiety. What worries you most about this pain? 5, identify catastrophization. So we're on the lookout for magnification or language that we can associate with helplessness, as we had mentioned before. 6, evaluate fear avoidance. Is the patient avoiding movements despite clearance that they can? 7, assess sleep. Do you have poor sleep quality? Is your sleep fragmented? 8, provide education. Explain how the nervous system is tied into this experience. 9, initiate a multimodal plan. Rehab, sleep optimization, mood treatment. And 10, refer if needed. Depression, suicidality, severe anxiety, and repeated failed interventions, all things that the psychiatrist can handle and help us with. These are my references, or some of. Does anybody have any questions for me?
Thank you so much, Dr. Eaton. That was a very stimulating and informative presentation. You made neuroanatomy very user-friendly. It's one of the best presentations I've seen, linking the neuroanatomy to the actually what is happening.
I've put my time in with neurology and I'm glad to show it off on occasion.
That it was well received. You told us about the bidirectional relationship of depression and anxiety on one side and pain on the other side. And I think that would say to us the importance of assessing for depression and anxiety in our patients with chronic pain.
Absolutely.
You pointed out that pain is beyond the physical and that there's a pain-fear cycle. Also, the importance of proper sleep. And you pointed out things that we as GPs can do in our day-to-day practice to help the patients through this cycle and also to work in a multidisciplinary way with our psychiatry colleagues and how to frame the referral. So all of that was very useful. I
actually see an interesting question in the chat that I'd love to respond to because it's a very interesting question. How to identify if the anxiety disorder predates the pain, and is anxiety or pain managed differently in that situation? That's such a good question. I don't know why you are anonymous, but bless you for that question. This is a very interesting question because yes, you can have the bidirectional relationship, sure, but you can also have two things happening concurrently that are completely independent. So it's absolutely possible that this patient could have been having symptoms of anxiety that long predates this pain exposure. And the pain or the chronic pain that they develop after whatever injury only worsens the symptoms. Now, in terms of identifying how that's going to be done, if it's chicken, egg, chicken, it goes back to a very careful and detailed history, which can be challenging from a psychiatric perspective in terms of identifying which symptoms came first. However, it's an academic matter because whether the anxiety disorder predates the pain or the anxiety comes after the pain, the anxiety is still anxiety, just like the pain is still pain. So it responds equally well to the same medications, and it means that you can treat it the exact same way. So translation, there is no difference between treating anxiety before pain or anxiety after pain. The only real difference is you may adjust some of your medications depending on the type of chronic pain that the patient is experiencing, i.e., if it's neuropathic, for example, you may consider a tricyclic as opposed to a SSRI first. However, at the end of the day, minor details are minor. Once we are identifying the anxiety symptoms and we initiate treatment, 9 times out of 10, we're going to see some improvement in symptomatology.
Thank you so much for that. And I would ask others who have questions, please put them in the Q&A tab. And Dr. Eden, if you could monitor the Q&A tab, if there are any questions that you want to answer there or that you would want to speak to when we have our question and answer session at the end. So
No
thank you
problems.
very much for an excellent presentation. We have been very fortunate this evening. As always, Dr. Ananuja has got some very erudite presenters for us, and we do appreciate that. We should have another sponsor presentation now from Abbott Nutritionals. Is anyone there here from Abbott?
Yes, I'm here. I'm just queuing up to show my
Yes.
face and to present.
Thank you very much, and welcome and thanks as always for your ongoing support.
But that's not a problem. I enjoy presenting to this group. Are you seeing my Abbott A?
We're seeing your name only. We're not seeing any slides as yet.
Oh. Tell me when you see the A, the Abbott A.
I will.
Oh, Lord. Okay.
As we wait, remember, if you have any questions for any of the presenters, put them in the Q&A tab, because at the end, we are going to have a question and answer session. And we can look at some of the questions that are not answered there.
So, Paul, you came back to Zoom and you started broadcasting because we're not seeing anything.
Okay, hold on. Back to Zoom.
Then share. There you go.
Okay, your screen is beginning to share now.
Start broadcast. Yeah, so we're seeing your desktop now.
Seeing the Abbott A?
Yeah, you just need to go to play from beginning.
Okay, awesome.
There you go. Yeah.
All right.
All right. Thanks again for the opportunity to present to this group, CCFP. Very accommodating. I've always enjoyed presenting to you guys. My name is Paul Russell, and I'm with Abbott Nutrition. So Abbott Nutrition has been around for more than 90 years, and it has dedicated to developing innovative products for persons to reach their nutritional goals at every stage of life. So going right into the products, here is a slide showing the various ensures. Actually, it's just a sample of the ensures that we have. And really the ideal thing is to find an ensure that fits your patient based on their nutritional goals that they want. So the first one we're going to look at is Ensure Max Protein. And Ensure Max Protein provides 30 grams of protein, high quality protein to support muscle health. It also has 1 gram of sugar. It has 25 essential vitamins and minerals. It has your 4 grams of fiber along with prebiotics. It's only 150 calories and it comes in assorted flavors, but the screen will show delicious French vanilla. It's gluten-free, suitable for lactose intolerance, and it's halal and kosher prepared. I should mention that most, if not all of our adult presentations are in fact suitable for lactose intolerance. It will not cause any discomfort due to because the lactose has been taken out. Now, if your patient does not like a milky-based drink, we have Ensure plant-based protein shake. It's vegan friendly with 100% plant-based protein and nutrients to support your immune health. It has 20 grams of plant-based protein, and it's made from fava beans and peas. It's 180 calories. It has your fiber. It has a small amount of sugar, 7 grams of sugar, no artificial colors, flavors, or sweeteners. And it comes in vanilla and chocolate. It's dairy-free, soy-free, it's gluten and lactose-free. For your persons who are living with diabetes, we have 3 of our presentations on screen. We actually had added a new one recently called Glucerna 1 gram sugar. So we have, okay, so you'll see it on the screen. Are you seeing the 4 on the screen? So currently we have 4 types of Glucernas in the stores. So that gives the clinicians some choices as to which Glucerna fits the patient in front of them. So it's all based on what your patient's needs are. The one we're going to focus on today is Glucerna Protein Smart Shake. And this has 30 grams of protein. It's only 150 calories. It's less than 1 carb choice. And it has nutrients to support immune system health. It's clinically proven to not spike blood sugar. And we have a Abbott coined word, which is carb steady. Simply means that it has complex carbohydrates that break down slowly over time, so it does not spike the patient's blood sugar. So they're better able to manage their blood sugar response. And for patients living with stubborn wounds that just won't heal, we have Juven. And Juven comes in 2 flavors currently on the market, orange and fruit punch. Now, Juven delivers essential nutrients to help support wound healing from the inside out so that your patient can get back to the things that they love. It's 2 sachets per day, and whether the wound is as a result of pressure injuries, diabetic foot wounds, surgical incisions, or acute or chronic wounds, Juven will help. So Juven, each packet mixes in 8 to 10 ounces of water or juice, and it contains arginine, which supports blood flow, the immune system, and protein production, which contributes to wound healing, glutamine, which is involved in the formation of collagen and supports the immune system. There's HMB, which helps to protect muscle cell wall and preserve and maintain muscle tissue. It has collagen peptides, which help to stimulate the formation of collagen at the wound site. And it has your micronutrients, vitamin C, E, B12, and zinc. And these components together have been clinically shown to support wound healing in as little as 2 weeks. So by taking 2 sachets per day, you can support healing from the inside out. And really, it's recommended to be used under medical supervision and in addition to a complete balanced diet. Now, I've dropped in this slide just to remind you that Pedialyte, which we all knew was great for the kids, is no longer just for children, but adults can use Pedialyte as well. And it's useful when you have excessive sweating or extreme heat, vomiting and diarrhea, or even for your pregnant patients. It's for mild and moderate rehydration. Just bear in mind that Pedialyte is adequate for rehydration. I want to thank you for the opportunity to present on Abbott's products. All our products are distributed by CareMed Group. And I will take the opportunity to put my information, my contact information in the chat. Whether you have any questions, queries, or concerns, feel free to reach out to me and I'll get back to you. Thank you very much.
Thank you very much, Mr. Rosella. Certainly, we are familiar with the range of Ensure and Lucerne. Personally, I was hearing of Juven for the first time, though I'm sure some of my colleagues might be familiar with it. And I am sure that these are things that we recommend to our patients on a regular basis. So thanks very much for the presentation today and also for your continued support of the CCFP Jamaica chapter.
Thanks again for having me.
We are winding down. I think you all would agree that we have had 3 excellent presentations, and I am sure that the 4th will live up to that as well. We have heard a lot about pain, but what about pain management? We have heard little bits and pieces as we went along, but I want to introduce to you Dr. Kelvin Metalor, a consultant anesthetist at the University Hospital of the West Indies, an associate lecturer in the Faculty of Medicine at the University of the West Indies. He did his undergraduate training at the University of Ibadan in Nigeria, where he graduated in 1992, and he went on to do his DM in anesthesia and intensive care at the University of the West Indies, completing in 1999. He did a fellowship in critical care at the University of Toronto in 2005 and postgraduate training in pain management at the University of Wales in Cardiff. He is a member of the Medical Association of Jamaica, the Jamaica Association of Anesthetists, the Neurocritical Care Society of America, and the British Society of Echocardiographers. His role today is now to bring it all together with the practical prescribing in pain management, and we look forward to hearing from him. Dr. Metalor.
Thank you, Dr. Golson. And let me thank the Caribbean College of Family Physicians for the opportunity to present again at your conference. Always a pleasure to be here. Let me share my slides. Please let me know if I'm doing it right. I'm not quite sure if
it's coming up.
It's coming up.
Yes, we are seeing it now, but you need to put it in slide
mode. Okay.
Slide mode now.
Slideshow, yeah. And I will start from the beginning. Is that good?
Right. You're good to go.
Okay, great. Excellent. Thank you very much. Good evening, everyone. Yeah. Okay, so this evening, I will be speaking with us on pain management, excellent topic that has been chosen by the Caribbean College in this current webinar. And the previous speakers have actually made my work so much easier, especially Dr. Eaton, who had actually taken the time to speak extensively on some of the things I would also have loved to talk about. And so it will make it easier for me to actually go a little faster because he really did an excellent job in going into details in those aspects of it, and you would soon find out why. All right, so here are some of my objectives for this particular presentation. So at the end of this presentation, we should be able to define pain, which Dr. Eaton and the other presenters also spoke to earlier on. We should look at the deleterious effect of pain on the various organ system, looking at various methods of assessment, which are essential for prescription, the factors that affect the level of pain. Some of those have been talked about, so I will go through whatever I have to go through very quickly. And methods of pain relief and management, and we will look at a few advantages and disadvantages of each method. This is a diagram or an image by René Descartes in 1664 called the Triathes of Man, demonstrating his theory of how the human body processes painful stimuli. And basically, you know, it's essentially the same. It hasn't changed very much. I mean, these guys were quite interesting. As far back as 1664, they pretty much could actually delineate the pain pathway for us just by simple observation. Pain is a universally understood sign of disease and the most common symptom bringing people to seek medical attention. It still remains the most common symptom, and I'm sure that if you actually do an audit of the reasons why your patients come, perhaps the significant majority of them would have come as a result of one form of pain or the other. But the interesting thing about that is that physicians have been struggling, through history to better understand pain and provide true relief for their patients. Despite all the knowledge, it's still quite a difficult thing to understand. So, and because of that, in the last couple of years, at least in the last 3 decades, there has been an increased emphasis on the assessment and the treatment of pain. And that's partly because the medical education has not focused on the fundamentals of pain medicine. If I were to ask some of us, about our experience, or as far as pain management is concerned in medical school, or even in undergrad and postgraduate school for some of us, we will actually recognize that quite a number of us have, over the years, not actually, oh, I'm sorry, just a minute. Yeah, okay, there. Can you still hear me?
Yes, we're hearing you.
Oh, thank you. Yeah, I thought something just went on my computer, so I wanted to make sure I got it right. Yeah, so our exposure to pain training in both undergraduate and postgraduate is rather limited for a significant number of us. And so that has become quite a bit of challenge. So I would begin the evening by giving us a case presentation. Patricia James, I just, it's a made up name. So if there's anybody by that name, it's not you, actually. This is just made up in terms of the name. Patricia James is a hotel worker aged 44 years who has had a long history of chronic back pain, probably work-related injury about 14 years prior. Past medical history is significant for hypertension, type 2 diabetes, and class 2 obesity. In terms of the lower back pain, she describes a pain that radiates to the left hip and the buttocks area, as well as the anterior thigh at times, occasional paresthesia to the left medial lower leg, as well as the dorsum of the foot. She rated her pain intensity as an average of 9 out of 10, usually aggravated by walking or physical activity. She has tried several pain medications and antidepressant, as well as outpatient rehabilitation program with very little success. Currently, her pain medication includes Panadine F, Midocam 150 milligram 3 times a day, both the Panadine F and the Midocam at 150 milligram 3 times a day. And she occasionally takes amitriptyline at night, but experiences significant constipation associated with her use of the pain medication. The pain interrupts her sleep every night, and she has significant fear avoidance, poor activity pacing, significant depressive symptoms, and nightmares related to her work injury. Physical examination revealed abnormal posture with elevated left pelvis, reduced lumbar range of motion, tenderness at the left sacroiliac joint and the piriformis area. She had a positive sign of sacroiliac joint dysfunction on the left with a positive straight leg raising test at about 60 degrees and a positive slump test. Her neurological examination otherwise were unremarkable. So what are your 3 top differentials and your most likely diagnosis, and how would you proceed with management of this patient? So I'll give you a little bit of time to think on that as we continue the presentation. So what exactly is pain? We know for sure, again, as we were told previously, that the International Association of the Study of Pain, that definition has become the standard definition for pain as an unpleasant sensory and emotional experience. And I want to highlight the term experience there, associated with actual or potential tissue damage or described in such terms. It's an unpleasant sensory and emotional experience. So it's very important that we don't reduce pain to just a sensation, that it's actually more than a sensation, it is an experience. So because of that, there's a physical component to it, the somatosensory. There is an emotional component, the somatoaffective. So because we have an emotional experience, so it is also influenced by other emotional states, and it can occur without tissue damage. It's processed and interpreted in the context of higher order cognitive processes. So what are the types of pain that we actually have to look at? I mean, for most of us, we tend to look at pain as acute or chronic when we look at pain as types. And the primary difference between the acute and the chronic pain being that the acute pain dissipates as the tissue heals, and chronic pain persists beyond the normal healing period. And a timeline on it has usually been between 3 to 6 months. Acute pain very often is a reflection of tissue damage, even though new evidence unifies the experience of acute and chronic pain conditions. So if we just run through the various types of pain that we tend to be very familiar with, the nociceptive pain, which may be somatic or visceral, the characteristic of the somatic pain, usually sharp or dull localized pain with burning sensation, or the visceral pain, which is often very poorly localized, deep cramping referred to remote or cutaneous sites. But these days, we've actually moved away from types of pain and began to look at pain from a model point of view. So we actually talk more about the models of pain today rather than types of pain. And Dr. Eaton spoke very extensively earlier on to us about the biopsychosocial model of pain, the BPD, which unifies the physical and the psychosocial aspects of pain, looking at the emotional, the cultural, the social, the religious, the financial, the existential, the physical factors that interact in a complex, multifactorial way to produce the experience of pain and suffering. Now, just a little bit at suffering. Suffering relates to the impact of pain on the whole person. It impacts the patient socially, psychologically, financially, spiritually, and can also influence family and personal functioning. Suffering is the inability to cope with adversity. This is a diagram or a schematic representation of what we tend to look at when we really look at pain, right? Looking at the physiological and the psychological aspect contribution that leads to pain. So let's narrow it down to the physical. What we know as the pain pathway, in our, neurology, neurosurgery, pain 101, where we actually have the pain receptor that is stimulated, and there are various stimuli that can stimulate our pain receptor, transmitted by the first order neuron via the spinal cord to all the various areas within the spinal cord and the brain, ultimately the cortex. And I will not go into the details of that because Dr. Eaton did most of that already. Here's another representation of that particular pain pathway, which we are all familiar with, and the various modulation, which we will spend some time to talk about when we actually look at the practical management of pain. From an injury, and there are so many things that can, create an injury. There are usually receptors there, what we often refer to as the pain receptors, that actually transduce this injury or this stimuli that creates the injury and allows it to be transferred via the neurons of the body, the first order neuron, the second order, the third order, ultimately to where pain is perceived in the various regions of the brain. If we zero in a little bit on the spinal cord very quickly, we actually see the Rexhead areas in the spinal cord. And these are important because as we begin to look at pain management, these are sections where most of the pharmacological as well as the non-pharmacological aspects of pain management, where intervention take place that allow us to be able to modulate and manage pain appropriately. All right. So when we look at these various ways with which we manage pain, we essentially focus on modulation. We talk a lot about modulation because that really has become the main way by which we actually look at pain management in modern times. Substances are usually released from tissue injury, peripherally when we look at peripheral modulation. And these substances, they stimulate nerve endings, and we have a barrage of substances, whether from substance P to potassium to hydrogen ion to various kinins, bradykinin, and etc. The various, vasoactive peptides, serotonin, epinephrine, calcitonin, gene-related peptide, etc. There are lots of substances that are capable, not just chemical substances, but we can also look at other form of mechanical substances that can actually create stimulation at the peripheral level. And as these things, as these neurons take these stimuli to the various sections of both the spinal cord and the brain, repetitive stimulation, for example, from prolonged painful conditions, can sensitize the neurons in the dorsal horn of the spinal cord and to a lesser extent in the peripheral stimulus, which leads to a phenomenon known as the wind-up phenomenon. The peripheral nerves and the nerves at the other levels of the central nervous system can also be sensitized, producing long-term synaptic changes in the cortical receptive areas, leading to remodeling, and these lead to maintain exaggerated pain perception. And of course, the processes of the chronic input, afferent input, leads to increased sensitivity, lowering the threshold, remodeling of the central nociceptive pathways, and the receptors attend, of course, central sensitization. So we can have both peripheral and central sensitization, and this wind-up phenomena can lead to increased accentuation of pain and generate the whole concept of what we, of course, lead to chronic pain ultimately if it's not properly managed. Before we reach management, what about pain measurement and assessment? Can pain actually be measured? Is it easy? Why do we need to measure pain? There are various scales that can be used to measure pain. We just mentioned a couple of them: the visual analog scale, the FACES scale, especially in the pediatric age group. Are they very useful? And in the 90s, the veterans hospitals of the United States actually began to push for pain to be recorded as a fifth vital sign. Various pain charts which can be used, all right, in terms of actually measuring pain. There are advantages of measuring pain because you want to have some objective assessment of what the pain levels of the patient, and the commonest tools that are often used, the VAS tool, because it's simple, it's caused a complex interaction between the physical and the psychosocial factor, is validated in a number of instances. It has its limitations. It's an inadequate tool. It can't completely assess the complex interaction between the physical and the psychosocial interaction. It is a unidimensional tool. It only assesses the global impact of suffering and not the individual factors that impact the perception of pain and suffering. So these are some of the tools which I'm sure a lot of us are quite familiar with, that looks at the various aspects of measuring pain. That's the FACES scale, the Wong-Baker FACES scale on the left, and on the right we look at the pain scales using the VAS, whether the numeric rating scores or the VAS pain scores. What about assessment of pain? It is actually better for us to actually look at pain assessment rather than just actually recording pain scores. And I want to walk us through what is often referred to, as the 4 Ps of pain assessment, the 4 Ps of the management, and we look at the 6 As of the follow-up. So the first one is the nature of the pain. What is this pain nature that you're actually looking at? Patients usually would describe their pain, and in the description of the pain, you can actually get to understand what is the nature of the pain that is being described by this pain. Is this an acute pain or is this a chronic pain? If this is a chronic pain, is there a neuropathic component to it? What actually is the nature of the pain that is being described to you? Are there comorbidities? So the second P, looking at the pathologies and the past medical history. Are there comorbidities that can actually influence this pain? What is the patient's performance, the 10th P? And what are the psychological, the psychiatric components to this pain? How can you assess it? These are important in assessing the patient's pain. Then we can look at the management strategies on the 4 Ps: the physical, the psychological, the pharmacological, which is the medication, and the procedure or interventions that may benefit this patient. And then we look at, if we have been able to look at the assessment of the pain and we have been able to look at our management strategies, then after the management of this patient, we will have to look at the follow-up. What are the activities of this patient? How do you assess these activities? What kinds of analgesia is this patient on? How do you follow that up? Are there adverse effects associated with this analgesia? Are there aberrant behaviors? You look at the affect and, of course, adequate documentation. I don't think we can speak enough on documentation. All right. So having looked at that, why should pain be treated? Do we need to treat pain? Why should it be treated? Dr. Eaton took us through quite a lot on the psychological and the psychiatric effects of untreated pain. Let's actually also look at some of the physical aspects of it. Are there physiological adverse effects associated with untreated pain? Yes, there are cardiovascular problems that can be associated with untreated pain. Untreated pain can lead to hypertension, tachycardia, increased systemic vascular resistance, increased myocardial oxygen demand. It can cause or worsen angina, and in patients, it can actually lead to heart failure. So there are cardiovascular morbidity associated with pain that is untreated or not properly treated. What about the respiratory system? Increased oxygen consumption, increased carbon dioxide production, increased work of breathing, hypoventilation in patients, atelectasis, ventilation perfusion mismatch, hypoxia, and you can all agree to me this actually would lead to a very poor and sometimes fatal outcome to patients. There are other systems. Your GI, decreased motility leading to ileus, and so you can have decrease in nutritional intake, increased gastric acid secretion, increased stress ulceration, increased risk of aspiration and pneumonitis, nausea, vomiting, and constipation, all associated with pain. And of course, genitourinary system, decreased motility leading to urinary retention. And then what about our endocrine system? We look at the stress response to pain, increased catabolic hormones, catecholamines and cortisol and glucagon, decreased anabolic hormones such as your insulin and your testosterone, increased protein catabolism, hypoglycemia, so poor glucose management, sodium and water retention, and we know all that is associated with increased sodium and water retention. So what about socially? It is inhumane to keep patients in pain. It is almost tantamount to torture. Ethically and morally, it belies the principle of beneficence and non-maleficence, and generally less motivated to get well. So there are problems that can be associated with either poorly managed pain or pain that is not managed at all. It still remains the number one reason why patients would come to see their family physician. And if at the end of the day, pain is not addressed, then for the patient, their problem has not been addressed, regardless of what else we find in the patient. Are there factors that influence pain? Yes, there are a lot of factors that influence pain, and we've heard of some of them. Individual variation in response to injury, physiological, behavioral, and cultural, and individual variation in response to treatment. All of this put together can lead to what we get out of it. Now, previous experiences and the response of the pain can actually lead to some of these challenges. All right. So we see there that in order for us to get the minimum effective, response to our analgesia, there are things that we need to do and we need to do right. There are other factors that influence pain. Motivation, such as income, health insurance, job satisfaction, comorbidity, and of course, our psychological or psychiatric issues such as depression, anxiety, and other factors. So how is pain treated? Starting with acute pain. Now, there are lots of ways, lots of things that come into the management of pain. All right, the non-pharmacological and the pharmacological aspect of it. So first of all, let's look at the broad concept of it. We need to remove the cause of the pain. There are pharmacological treatment, which we can look at so many non-opioid as well as opioid drugs, and we'll talk about those in a few minutes. Regional anesthesia, which can be used, or analgesia. And then we look at the physical method. I will focus a little bit more on the physical method because there is really a move, to lay or to focus our attention significantly on the non-pharmacological methods of pain management, and I would speak a little bit of that and speak less on the pharmacological method of pain management. There are lots of physical methods involved, whether it's physiotherapy, manipulation, transcutaneous electrical nerve stimulation, acupuncture, ice, rest and relaxation, psychological methods, many of which Dr. Eaton spoke about already, relaxations, psychological intervention, hypnosis, etc. All right, these are all various methods that we are going to speak about just a little bit. Now, in terms of the opioids, which we are very resistant to these days in terms of use of management of pain, and the move again is to move away as much as possible for opioid, using them as a last means of pain management. There are so many opioids and so many ways of administration. I mean, the prototype opioid there, which of course the morphine, various routes of administration, whether enteral, transdermal, transmucosal, subcutaneous, and the various other parenteral ways of administration, IM, IV, PR, epidural, subarachnoid, of course, for patients who would be in hospital at that particular point in time, and the local anesthetics. All right, so we look at the various, bring us back again to this diagram. We look at the various pathways of our administration of opioids in acute pain. So initially we look at the enteral routes when we need to administer various analgesics to this patient. Still the most favored routes of administration, whether it's by per orum or per rectum. All right, usually ideal for mild to moderate pain, usually limited by absorption. First pass metabolism might limit the availability of the drugs, and of course it's also very useful for what we may refer to as preemptive analgesia. All right, your gastrointestinal tract is usually affected by various things. If the patient has nausea and vomiting, risk of aspiration, etc. Your rectum has a dual venous drainage system, and of course the first pass effect can lessen the eventual drug that is bioavailable to the patient. All right. Now, transdermal, and I mean, locally, we do have transdermal fentanyl that is available. That's probably about the transdermal opioid. It's actually a pretty good way of administering drug if we have to use it, because it's very, very excellent for chronic pain. I mean, the distribution and the absorption and distribution is steady, and it has a long lag time. And it is actually and the incidences of opioid addiction is actually less, has been found to be less with transdermal administration, and that's simply because of the rate in the slow release of the drug, the rate and the slow rate of administration, and you find that you do not get those highs that you get when you administer the quick release opioids, and so it's really an excellent way if it comes to that. Subcutaneous is actually a very excellent way, less painful, absorption again over time. And of course, we have transmucosal, which is a quick release administration. There are parenteral routes, other parenteral routes, such as intramuscular, for patients who are in acute severe pain. Intramuscular injections are usually, not the ideal ways of administering drugs because of the, if you look at that graph there, you realize that where you need a steady state to maintain constant pain, you do have these peaks and trough that comes with intramuscular administration of drugs, and it's very difficult to maintain a steady state with them, especially when they are administered over a long time period, such as Q4, Q6, which is usually how they tend to administer them in hospitals. Intravenously, again, these are hospital means of administering drug. It can be intermittent bolus, continuous infusion, of course, patient-controlled analgesia, which is really actually the ideal way of doing it for patients who are in severe pain. Excellent administration, good patient satisfaction, lower drug consumption if it's administered that way. What about combination therapy, routes and drugs? All right, looking at this particular diagram here, which again, I'm sure that quite a number of us are very familiar with the WHO analgesic ladder for treating cancer pain, which has now been adopted into treating non-cancer pain as well. The various steps and the various ladder, or the reverse ladder, depending on the severity of the pain of the patient that you are dealing with, starting from mild to moderate to severe, starting with simple analgesics, acetaminophen, the non-steroidals, and the various adjuncts. What I want to remind us of is a ladder, and so you are actually adding on. What you have found in quite a number of instances is that patients, when they move on to moderate the medications that you use by patients that you have classified to be in moderate pain, they actually stop the ones that are being used as the mild. That's not really the intention. The intention is that it's supposed to be an add-on and not a substitution. And of course, you're moving from simple drugs like acetaminophen to, combination drugs like codeine or combined codeine with hydrocodone or oxycodone, tramadol and the various adjuncts or adjuvants, and then to severe use of morphine, hydromorphone, and the high-level opioids. All right, pain therapy, all right, there are 5 simple steps that's still valid. The oral route still remains the best route of administration, at least is the easiest route of administration on outpatient basis. It's probably best round the clock or by slow release, which gives you round the clock. You match your treatment to your pain intensity, you individualize treatment, and you pay attention to details. All right, a 4th level has been added as we begin to look at the chronic nature of pain, especially neuropathic pain, and that's the use of adjuvants, or what used to be referred to as adjuvants, which are now being classified as actual primary pain medications, talking about the anticonvulsants, the antidepressants, the anxiolytic, the bidirectional movement of it, and these drugs add on the neuropathic pain. Why is this important? Because recent studies have begun to focus and to emphasize on the role of the neuropathic pain and how it has become perhaps maybe more than anything else, the biggest component to pain management today. All right, this is a rather busy diagram, which basically shows us, what the role of the central role of neuropathic pain. If you look at it there, if I look at the neuropathic component to pain, we find that this is actually becoming perhaps, as far as pain is concerned, the biggest reasons why patients actually come to see their family physicians. Whether these patients are patients that are diabetic and have, diabetic neuropathy, or patients with chronic kidney diseases and they come with neuropathy, or post-surgical pain, and so they come with post-surgical neuropathy, or patients that have chronic conditions such as arthritis, and they have now come with arthritic pain with neuropathy. So what you're finding now is that neuropathic pain now occupies a central primary role in pain complaints for patients who come to see the general practitioner or the family physician. And so managing neuropathic pain has become a significant problem. In fact, far more important than managing acute pain. Acute pain that is improperly managed almost invariably will have a neuropathic component to it. And so we spend the next few minutes just looking at managing the neuropathic pain. The diagnosis and the initial assessment of neuropathic pain they will tend to come. These are the patients that will come to you and complaining of burning pain, stabbing, electric shock, tingling, allodynia, which is really pain from a harmless stimuli. And there are various screening tools that we use in looking for neuropathy. And I think Dr. Eaton also spoke on a few of them. DN4, the pain detect tool. Your physical examination remains very important. You assess your sensory, your motor, and your autonomic changes in these patients. And as far as management is concerned, let's look at it from non-pharmacological management. Non-pharmacological management, which includes patient's education. And in patient education, number one thing is that you have to set a realistic expectation. Very often, the patient might come to the family physician and they want you to take away the pain. Pain reduction takes time. And by the time you develop neuropathy, it is highly unlikely that you are going to be able to make the pain go away. So do not give a false expectation to your patient. You are highly unlikely to make that pain go away. Now, the most important thing is physical activity. All right, you are talking about gentle, consistent exercise that improves mood and reduce pain. The primary objective in managing this patient is function. You're trying your primary goal, in addition to reduction of the pain intensity, is to establish function for this patient. This patient has to be functional. Functional activity, especially physical activity where possible, is critical, is crucial, and it should be the central theme around which all conversation should go. So we have to keep reminding the patient that the primary goal here is to get you functional as we aim for pain reduction. All right. And there are many, many ways. Whereas previously we used to look at pain management as primary pharmacological and secondary psychological therapy, in modern times, it actually reversed. It's actually primary psychological therapy and secondary pharmacological, or both of them go together. All right. And so we are actually looking at being very involved in the psychological therapy in terms of patients that will present. And most patients actually present outside of the acute levels, because by the time majority of the patients present to their family physicians, they have actually done a lot of pharmacological therapy. They've gone through the rounds, either self-medicated or medicated by family members with all sorts of things. So there you have to. So for the general practitioner, I would actually say, I would say to most of my family physician friends that at least a reasonable detailed knowledge in some basic psychological therapy is essential for any family practitioner at the very level, because it's so critical, it's so important in pain management today that it has to be built into family practice without a shadow of doubt, because early intervention is the most important determinant of good outcome. And by early intervention, we are actually talking about psychological intervention in addition to our pharmacological intervention. So whether it be cognitive behavioral therapy for pain management or other forms of therapy, in addition to sleep hygiene for crucial management of patient that has a significant impact of chronic pain, it is crucial. If you get the patient early, so within the first 3 months, within the first 12 weeks of intervention is critical to good outcome. All right. So most patients that will do well or do much better are patients that get that very early intervention. All right. So key consideration for timing and implementation of pharmacological treatment as well. Prompt initiation is critical to prevent sensitization of the nervous system, because by the time it takes a couple days to weeks for your nervous system to undergo that plasticity and sensitization for it to be upregulated or to be hypersensitive, and for you to begin to develop chronic pain in various forms, whether it is very early stages of chronic pain, or whether you have progressed into significant neuropathic pain, or you have even gone as far as becoming allodyna. And then all the psychological and the psychosocial component of that accompanies that begins to set in for this patient, and it becomes a very difficult situation to manage. And so prompt initiation, appropriate initiation is critical. Gradual titration of your medication, beginning at low dose and gradually up titrating over a period of time, whether it's 2 to 4 weeks and sometimes up to a 12-week period of your titration. So early intervention is critical. Expected onset, and again expectation. For most of the medications that you would use, or most of the pharmacological therapy, takes anything between 1 to 2 weeks to peak. And so time is of the essence, and it may take up to 12 weeks for you to get a full therapeutic response. And you probably will have to need evaluation period, a trial of about 6 to 12 weeks or 6 to 8 weeks in most instances, to see how your patient is going to do before you actually begin to think about whether you need to up your medication or you need to change them. All right. In terms of looking for an algorithm, by the time a lot of patients present to you, you realize that when you actually do a detailed examination to them, a lot of persons will present with some level of sensitivity. All right. The skin is sensitive. They have allodyna, they have hyperalgesia. And we find that maybe starting with topical agents, like for if the pain is localized, your 5 or 8% lidocaine patch does a good job. Your capsaicin does a good job if it's applied under medical supervision. And so you find that for a number of patients, these actually will help reduce the sensitivity that they may experience. Your stepwise treatment algorithm, starting with one agent at a low dose, you titrate or increase your doses for looking for tolerability over a period of 2 to about 8 weeks. And you evaluate, assess, and reassess. Assess pain relief. Your goal is a 30% reduction in pain. Do not aim for too high. What you tend to find, I do sometimes see a fair number of patients who have, doctor shop, and the main reason is not because the doctors have done a bad job. They've actually done an excellent job, but they have actually given an unexpected realization to the patient, unrealistic expectation to the patient. All right, patients expect to get better. You know, they want a magic wand. So you got to fix this right now. It just, no, majority of the time, it's not going to happen that way. For the majority of patients, over 80% of patients will not have instantaneous relief. It's going to take time. You probably, if you get a greater than 30% reduction in pain in this patient, that's a great place to start. And you go from there over a period of time and keep the goal on function. Function. If we keep our eyes on the fact that we want to get you functional, you need to get back your life. You need to get back to work. You need to get back activities of daily living. You need to get back activities of enjoyment. You need to be able to function. You would have won 80% of the fight. Switch or combine. If your first-line agent fails, switch to another first-line agent. If partial relief is achieved, consider combining agents with different mechanisms, for example, a gabapentin and tricyclic antidepressant. Avoid or reserve opioids. These are generally second-line or third-line drugs due to risk dependency. In fact, some guidelines today are actually advising against using them entirely. All right, what are our first-line agents? Our first-line agents have the strongest evidence for efficacy. The gabapentinoids, the pregabalin and the gabapentin still remain perhaps the best in the market. The great drugs, titrating pregabalin. I know 25 milligram pregabalin is not available in Jamaica. I'm not quite sure if it's available now. The very low dose for the elderly patients not available. They're, starting at night for patients that would tolerate it. Most patients, majority of patients would tolerate pregabalin at 25 milligrams, even amongst the elderly. Just unfortunately, I don't think we have it available in Jamaica at this point in time. All right, you can titrate all the way up to 75 milligrams per day or to 150 milligrams twice daily. And there have been instances people have actually used it out of the label to 150 milligrams TID, titrating up to 300 to 600 milligrams per day. All right, gabapentin, which I do love gabapentin actually, because pregabalin, the difference between pregabalin and gabapentin, pregabalin has a linear relationship. Your response is directly is almost dose related for most patients. Gabapentin does not have a linear relationship in terms of dose response, and so it's a little different, gives you a little bit more room to use as well, and you can go up to a maximum of 600 milligrams per day in very, very severe neuropathic pain. The tricyclic antidepressants, the old drugs in the market, but they work great. The dosages for pain management much smaller than what they will use in depression treatment. Anything between 5 to 10 milligrams up to a maximum about 25 milligrams are usually adequate in pain management. Where do they play a great role? Apart from the fact that these drugs are great combining with the gabapentinoids, they're also very good for sleep. Okay, in elderly patients, you need to be cautious with its use because it does have anticholinergic effects, and so it can actually really give them anticholinergic symptoms. Dr. Eaton spoke about the serotonin norepinephrine reuptake inhibitor, SNRI drugs. I mean, duloxetine, great drug, unfortunately out of the market, especially for patients with diabetic neuropathy. It was a great drug for diabetic neuropathy. Venlafaxine still available and a great drug as well. But I found that the duloxetine was very, very good for patients with diabetic neuropathy, but I think it's been withdrawn from the market, like you said. All right, just moving on very quickly. What about the physical reactivation exercise program? You have to include an exercise program in the management of your chronic pain patient. It's crucial. It is a prescription. It is not an option. And so in sitting down to have a conversation with your patient, it has to be absolutely clear. In your conversation with your patient, this is part of your prescription. It is not an option for you if you want to get better. Psychological involvement, your pain education, management of poor pacing, fear avoidance, anxiety, and stress management. All right. And so these are crucial. They are critical to good outcome, not just the pharmacology. Various techniques, which we spoke about, CBT, acceptance-based treatments, and mindfulness, all the various techniques that are being used and that now available at various training level. And I really believe that every family physician that would see pain patients, and I think pain always constitutes a significant proportion of the patient, should have some training, at least some basic level training in psychology, psychotherapy, because it's so crucial and early intervention is important. Of course, we talked about the pharmacological and the medications, the appropriate medication, further optimization of medication, different types of medication. And then we talk about procedure and intervention, the use of local anesthetic and corticosteroids, which is at this point, actually by now, the patient actually should be referred to see a pain specialist. But again, there are lots of good programs that are now available for family physician, at least at the basic level, on the use of local anesthetic and corticosteroid injections that are very helpful and that are easy to administer even at the office, that will improve the pain condition of the patient. And this will include things as simple as trigger point injection, as long as we know exactly what to do, how to assess for patients, what to do, how to inject, and how to be safe with it. They are very, very, very safe if they are done properly. All right. There are special considerations. The elderly patients, you tend to start with much lower doses and titrate slower to prevent cognitive impairment and falls in this patient if we are using drugs like the gabapentinoids, or we are going to use the tricyclic antidepressants. Patients with renal impairment, there needs to be dose adjustment with the gabapentinoids. Again, we have to take that into consideration. Especially we'll talk about trigeminal neuralgia. First line treatment for TGN still remains carbamazepine, and great drug for it. And of course, we can add other drugs to it, maybe Keppra, or we add other drugs to them for patients with TGN, and manage the other aspects of their care. And if it becomes resistant, then we can consider for procedures. Acute versus chronic. In conditions like post-hepatic neuralgia, which again, we have to remember early antiviral treatment combined with the gabapentinoids or TCA is recommended, and it still remains the first line of treatment. And patients that may not respond to that may actually respond to injections, local injections into the nerve roots that is involved to break the pain cycle while you continue on your treatments. Refractory cases, you should consider referring to a pain specialist for interventional procedures such as either spinal cord stimulations or, in rare cases, surgical intervention. Follow-up assessment, important. Activities, you have to also record your follow-up assessment, the activities of the patient. Are there improvements in the activities, in the functional status of the patient after introducing appropriate management strategies? In your analgesia, to assess the change in the pain levels, whether you are using the VAS scores, the NROS, or you are using questionnaires such as the brief pain inventory, you must have an objective way of assessing the effectiveness of your analgesia. Are there adverse effects? Is the patient experiencing any adverse effect? Are there aberrant behavior, especially if your patients are on opioid or opioid-related medications, all right? Or some non-opioid medications such as the benzodiazepine, which again are not favored. You look for things like unsanctioned dose escalation. Many times patients might come and they are increasing their dosages, or they are using it for other reasons other than the pain. Reported missing scripts, doctor shopping, possible inappropriate uses, diversion, and possible overuse or overdose. So these are things that need to be documented in your follow-up with the patient, whether they are absent or they are present. You look for affect. Are there changes in the mood of the patient with the chronic pain or due to the medications that the patient is receiving? Adequate documentation, quality, high standard clinical practice. Risky areas such as opioid use and polypharmacy must be documented. You have to have very good documentations for them. So in terms of going back to our patient who, that we presented. So what happened to PJ? PJ got some injection of local anesthetic and corticosteroids into the sacroiliac joint. All right, she was diagnosed with significant sacroiliitis. She got injection in her sacroiliac joint, and she reported a significant improvement of her low back pain for several weeks. Several weeks she was pain-free. She was able to go back to work, at least to some extent. However, the pain was aggravated again at work. What do we think happened here? Now, one of the biggest mistakes that we often make with patients, and we all do sometimes, is that we think we fix the pain. Pain is a very complex, especially chronic pain is a very complex thing. Fixing the pain without adequate education of the patient and having a multidisciplinary team approach to the management of this patient often leads to recurrence, and which is what happened with PJ. She represented to her family physician about 5 months later after the injection, seeking help for the pain again. Now, on more detailed examination, it realized that the family physician realized that she had not attended the recommended physiotherapy sessions, and she had not been to her psychological therapy sessions either. So she did not have a grasp of the management of her pain. For her, the management of her pain revolved around fixing it. Yes, she got her local injection. She got an excellent response to it, and she seemed to have been doing fairly well on her medication. She was able to go back to work, but her pain recurred because the entire package that was needed for her to have a sustained relief and sustained outcome was not followed through. So on re-examination by the family physician, realized that this patient had significant myofascial tenderness at the left gluteal area and tenderness at the left sacroiliac joint area. This time around, they spent the time to give a proper explanation and education regarding the nature of her pain and the importance of the psychosocial barriers to recovery. She got trigger point injection into the left gluteal area to temporarily reduce the muscle tension and the localized pain, and to allow her to participate in the physiotherapy session and to participate in her psychotherapy. All right. She went to sessions with a chronic pain psychotherapist who prescribed appropriate exercise with short-term use of a sacroiliac joint belt. She also saw her psychologist who assisted in the management of her mood, anxiety, and stress-related condition. After 2 months, her visual analog score had decreased from 10 out of 10 to about 2 or 3 out of 10. She was functional. She was able to return to work. More importantly, she had a positive outlook and had a much better understanding of the comprehensive multidisciplinary pain management, and she was able to do better, and she was able to get her life back together. So that's my presentation. And so it's critically important for us, that we, at this point in time, make sure that our management of our patient is multidisciplinary. They are part of the management and they follow through with the various things that we prescribe. Thank you very much. And thanks again for the opportunity to present to you.
Thank you so much, Dr. Metelo. Again, a very engaging presentation. You moved us from thinking about types of pain to a model of pain which speaks to the biopsychosocial model of pain and pain as an experience. You reminded us of the various pain scales and charts that are available, and that in pain assessment, there are 4 Ps in the management and 6 As in the follow-up, which I'm sure we will find very useful in our day-to-day practice. You reminded us of the consequences of untreated pain and the treatment modalities, both the pharmacological and the non-pharmacological, and the importance of stressing to the need for improvement in function and not just pain relief. And also the importance of patient education and a holistic management. So thank you very, very much for your presentation. We do have a few questions in the Q&A. I'm going to bring those up and let us go through. I think our presenters are still with us. I see Dr. Mills, Dr. Daly, Dr. Metelo. I'm not sure if Dr. Eaton is still here, but let us look at the questions. And the first question I'm seeing that's not yet answered is, how do you compare Baralgin and Buscopan Plus? I believe this was a question for Dr. Mills when he was speaking. Do you have any comment on that, Dr. Mills?
Sorry, I thought it was for the farmer rep actually. But
Oh,
you hearing me?
yes, I'm hearing you.
Okay. Sorry. My background is not great. I think it was for the farmer rep, but essentially the two don't have a significant role to play with regards to chronic abdominal pain, especially the buscopan. The buscopan is used for acute pain, not for chronic pain, whereas the baralgin, we can use it also for
Okay, are we losing Dr. Mills?
luminal issue. We tend to go
Okay.
with buscopan as compared to the baralgin, which is a more general approach to pain management, but neither are used for chronic pain.
Okay, thanks for that, Dr. Mills. Dr. Eaton, a question here, do virgins have PID? Don't know, would you like to address that, Dr. Daly?
Yeah, hello?
Yes, I'm hearing you now.
It's an interesting question, but
First of all, you have to define virgin, because sometimes there can be some kind of interaction that does not include penetration, but there may still be some exchange of fluids, I would imagine. What say you?
You answer that question to me as well. I mean, it depends on what they call intercourse too, because there can be intercourse without penile penetration too. There can be sexual interaction, same sex, which they may not consider to be, they may still consider themselves to be virgin. So quite often, technically speaking, you would need culture and sensitivity, microbiological confirmation to say this is PID. But the World Health Organization, everyone, as we know in common practice, we tend to treat and assume that diagnosis based on risk factors, how the patient presents, and not necessarily wait on laboratory confirmation. Because even when you make the test can also be negative because of how fastidious they are. So I would presume that based upon history and someone's sexual history, if they haven't had any sexual contact before and they present with pelvic pain, then PID wouldn't be your top differential. Yeah.
Right. Thanks for that. At this point, I want to acknowledge that we do have persons joining us from across the Caribbean, and we are very appreciative of your involvement in our CME program. There's a question here that's really for the drug group. I think it was Mr. Russell. Someone was asking if Juven is available in Trinidad and Tobago. Not sure if our rep here could answer that, or if we would have to direct you to your rep there. There is a question, I think it was Dr. Mittelor who mentioned the slump test, and someone was asking what exactly is the slump test. Was it you, Dr. Mittelor, that mentioned that?
Oh, yes. Yeah, right. The slump test is similar to the straight leg raising test, which is one of the tests that you actually would use to check for irritative symptoms in a patient who probably has a radiculopathy, all right? Radiculopathic pain. I'm sure that most persons will be familiar with a straight leg raising test, which tends to become positive at about 30 degrees and increasing. A slump test is a collateral for that. It tends to be actually used in patients that have spinal stenosis and also in diabetic patients as well. So if you just imagine a patient that is just slumped over, kind of, you're in a sitting position, you just slump over. What you're actually doing is you're increasing your tension with your legs straightened out. You're increasing tension on your spinal nerves. And if you do have if you have an irritative syndrome, then you'll get a positive. So you basically can also, the other way of doing that is that you can actually just flex the legs, all right? You can, hyperflex the legs while you ask the patient to slump towards you, and you will elicit a significant painful response if the person has irritation of that particular nerve range. And so it's usually for the lower limbs.
Thanks very much. Also for you, do you have views on the use of high-frequency sound waves for pain management?
Yes, there are several non-pharmacological methods for pain management. We didn't have the time to go into that. That would range from whether it's heat therapy, cold therapies, ultrasonic therapies, radio frequencies. There are several, depending on the type of pain that the patient has, and also the what surrounds it, especially for low back pain in particular, and for myofascial pains. Patients who would have, trigger points. You find that a lot of physiotherapists, we use high frequencies or low frequency that will generate heat, ultrasonic systems that will generate heat at low frequency. The frequencies that you use will depend on how deep the pain is. The higher frequencies for more superficial structures that are involved, if it's the tendons or the nerves, or around the tendons and the nerves that are superficial. For deeper muscles, you probably need a lower frequency, because the lower frequency, the higher the power and the greater the penetrance for it to be able to affect whatever area. So yes, there are. And there are other things that have been introduced. There are magnetic radio frequencies that are currently available for different kinds of pain, especially pain of the central nervous system, that's head and neck pain. Patients with certain characteristics of headaches, which are a different kind of pain entirely. Patients with certain kinds of neck pain. And so there are magnetic pains that are in magnetic frequency systems that are currently available that are being tested, and that some of the results are actually quite encouraging, that are currently being used in various kinds of pain. And some of these are some to some extent are available in Jamaica, very few, but they're available. These are non-pharmacological ways of managing pain today, which are being found to be quite interesting and quite helpful, actually.
Okay, thanks very much for that. There's a question here. I'm not sure if it can be answered in a short way in this forum. Someone is asking, how does income affect pain? And I know certainly multiple speakers spoke about the biopsychosocial influence on pain. And I think this is where income would come in. I'm not sure if anyone wants to actually say anything specific about income and pain.
I will attempt that, and I'll attempt that by telling you about a study that was done in Sweden that looked not directly at pain, but pain was a surrogate for it. They looked at the number of young people. They put them on a treadmill. It was meant for exercise tolerance, but it shows you the power of income. They put them on a treadmill, and they had two groups of persons on a treadmill, and one group was connected to rehydration, glucose, all sorts of things that you need to keep your muscles going. And the other group, they put a container there, and they put Swedish krona into the container, and they put them on treadmills, and they started an exercise just to see. I mean, these were propensity matched groups of persons, just to see who would outlast each other. So for every 10 minutes that you survived on the treadmill, they gave you extra kronos, and they gave more money. And whereas the other group, they gave them glucose, they gave them water, they gave them everything that they needed. And the people who got the money far outlasted the persons who got everything that you needed physiologically to survive. So what was their conclusion? Their conclusion was that financial incentives perhaps performed better than the other things that they used. All right. Now that's just a study. It wasn't really for pain, but you can draw a pain conclusion from it. But the biopsychosocial model of pain actually tells us that a lot of persons who actually present with pain, and I'm sure that quite a number of us who have seen patients in family practice have sometimes been confused by some patients that you might see and wonder if there is a financial incentive why this patient may or may not be getting better. We do see quite a number of patients from certain sector of the societies who have injuries, and where financial incentives are involved, it is very difficult for you to adequately treat these patients. I've seen quite a few of them. I've seen quite a number of them from the hotel industry. There was a particular hotel, I won't call the name of the hotel, where one of the workers suffered significant injury on the elevator. Significant. It was a free fall on the elevator, and she was significantly injured. And she was sent to me for a second opinion and for a report. Saw the patient, she had significant injury, but shortly, because she got significant compensation because of the nature of her injury, over a period of 3 months, I saw a significant number of workers from that same hotel, complaining of injury of similar nature, asking for reports, all right, to get, so we have to be very careful. There's a two-way to it. Adequate assessment is very, very important, and know that there are secondary gains for some persons why they may not improve, and they need proper evaluation. They need to be seen, appropriate, psychological, psychiatric evaluation to make sure that, secondary gain is not a hidden factor here.
All right. Thanks very much for that. Time won't allow us to answer all the questions live, but if the presenters could look and see if there are any others that they would answer in the Q&A block. The last one I would ask is, someone is asking, what is the role of CBD, cannabidiol, in the management of chronic pain? I think in our setting, we would really like to hear an opinion on that.
Yeah, I don't know if Dr. Eaton wants to take it, or you.
I'm not sure if Dr. Eaton is still here.
Yeah, CBD is widely used. I didn't mention it, it's really on oversight, but CBD has an increasing role in the management of chronic pain. It has been proven without a doubt in a lot of studies, a lot of well-done studies, that CBD has significant properties that improves pretty much every aspect of neuropathic pain or chronic pain in general, whether it's spasms, whether it's mood, that is for people who are responsive to it. And there are a particular group of persons that actually have been found to be pretty good with CBD, and especially the oil, actually. And in regards to that, specifically I mentioned patients with Parkinson's disease and a lot of spasms, a lot of tremors, and a lot of pain associated with it. They found them to be very, very, a significant proportion of them to respond quite well to it. Now, what hasn't been fully documented in the studies is just the phenotypes of it.
Okay.
At this point in time. So we don't know yet which groups of patients are more likely, because it's not across the board. You don't get a response across the board, but definitely there's a response. And so the studies are ongoing. If it can be narrowed down to give us the phenotypical expressions of the groups of patients that are likely to benefit from CBD. And so CBD we're currently using CBD a lot in pain management. And we're finding that certain groups of patients are more likely to respond to it. And which types of CBD you are likely more to respond to is another matter entirely. But yes, it does have a role, a growing role in management of chronic pain.
Thank you very much. And thank you so much to all the speakers, but I will not steal the thunder of the person who is going to give the formal vote of thanks, Dr. Dane Levy, the Secretary of CCFP Jamaica chapter. I invite you now to do the formal vote of thanks.
Good evening, everyone, all my colleagues, and all the participants in this wonderful and informative, timely, excellent, and such a great webinar. I was already introduced, and thank you, Arlene, for doing that. And also thank you for giving us such a wonderful, what should I say, time. You took us smoothly and seamlessly through the duration of this webinar. Of course, Dr. Standard Goldson is a family physician and one of our executive board members. It is, of course, always a pleasure and a good pleasure. And it is the task of mine, as she pointed out, to say thanks to all. And indeed, it is good to give thanks. To Dr. Arlene Henry Dawkins, who offered prayers for us for the success of this webinar, which indeed it was. I say thank you on behalf of the Caribbean College of Family Physicians Jamaican chapter. To our president, Dr. Seni Onanuju, who gave us the opening remarks and prepared the way for the presenters to do their thing. Of course, she has an integral role in the formation, in the preparation of the webinar in every aspect, in getting the presenters and making sure that everything was done in an orderly fashion. Thanks to our president, Dr. Onanuju. To our presenters, beginning with Dr. Mike Mills, consultant gastroenterologist, and presented on chronic abdominal pain. It was comprehensive, it was detailed, it was informative. It was indeed something that we all benefited from this presentation. Following that, Dr. Christopher Daly, consultant obstetrician and gynecologist. Again, an excellent presentation, of course, geared towards the family physicians, sorting out the complex presentations of pain and highlighting, of course, how important it is for us to make the diagnosis quickly and, of course, to refer in case we need to do that. Dr. Jordan Eaton, consultant psychiatrist, gave us also a very excellent, wonderful, and informative presentation. And it really highlighted how pain is being looked at in our modern era, and was also very, very informative. It highlighted some new dimensions, the new ways of assessing pain, and of course, ways of treating pain. Dr. Kelvin Metalor, he closed the innings, and of course, he's a consultant anesthesiologist, and he gave us, again, an excellent presentation on the treatment of pain and how pain is being classified, just to complement what Dr. Jordan Eaton did in his presentation. And I think all in all, the presentations were excellent, informative, they were detailed, they were comprehensive, and they were designed to empower us and improve our standard of care of our patients. These physicians are some of the most brilliant minds in our profession, and this was displayed by the level of their presentations. We must also say thanks to our sponsors, and these were Facey Pharmaceuticals, Servicare, Indus Life Sciences, Abbott Nutritionals, and also listed was Viatris Advetis. To our participants from all over the Caribbean, I'm sure you were very appreciative of this very informative webinar, very timely, and I'm sure you would have benefited from all the presentations that we were able to see this evening, this afternoon. To Oldgate Solutions and Samuel Heron for his excellent technical support. Sam has been with us, I think, for at least 5 years, if not more, and always and getting even more excellent in his presentation and in his support of the presentations. We always look forward to hearing his calm, informative voice that sorts out all the problems that we might run into as we prepare to do these presentations. To Mrs. Lynn Thompson Hyatt, our administrator, and to her administrative assistants, thanks to you as well. All in all, this evening, I think all would share my sentiments in saying this was indeed an excellent webinar, well organized, well presented, well moderated, and so very informative. Thanks again to one and all, and God bless you so much. Thanks again.
Thanks so much, Dr. Levy. Nothing remains but to wish you all a good evening. Dr. Levy mentioned that Dr. Metalor closed the innings, referring to cricket. Let us hope our cricketers tomorrow can emulate what was presented today and give us an excellent performance tomorrow in the T20 World Cup.
Indeed.
Good evening to you all, and thank you all for taking the time to be with us today. Good night.
Pain affects every area of medicine.
Guardians of Caribbean Health, the vital role of family physicians. Across the sun-kissed islands of the Caribbean, family physicians stand as pillars of their communities. They are the trusted caregivers who know their patients by name, their histories, and their families. These dedicated professionals provide comprehensive medical care throughout their patients' lives. From the bustling streets to the tranquil shores of the Caribbean islands, family physicians are the first line of defense against illness. They treat a wide range of conditions, from common colds to chronic diseases. They are also instrumental in preventative care, promoting healthy lifestyles and early detection of potential problems. The importance of family physicians extends beyond their clinical skills. They are deeply embedded in their communities, understanding the unique cultural and social factors that influence health outcomes. This intimate knowledge allows them to provide care that is both effective and culturally sensitive. In a region facing challenges such as limited healthcare resources and rising rates of chronic diseases, the role of the family physician is more crucial than ever. Their dedication, compassion, and expertise are essential for building a healthier future for the Caribbean. A legacy of care, the Caribbean College of Family Physicians. For over 2 decades, the Caribbean College of Family Physicians, or CCFP, has been a driving force in advancing family medicine across the region. Established in 1987, CCFP is dedicated to improving the health of Caribbean people by promoting and maintaining high standards in general practice. The organization achieves this through education, advocacy, and fostering a strong network of family physicians. At the heart of CCFP's mission lies a commitment to people-centered, continuous care. This approach recognizes that healthcare extends beyond simply treating illness. It's about understanding the individual needs of each patient and providing holistic care throughout their lives. CCFP provides its members with valuable resources, including continuing medical education, professional development opportunities, and access to the latest research in family medicine. These resources equip physicians with the knowledge and skills they need to provide the highest quality care to their patients. Through its unwavering commitment to excellence in family medicine, CCFP plays a vital role in shaping a healthier future for the Caribbean. Its work empowers physicians to be effective leaders and advocates for the well-being of their communities. Global Impact, Regional Action, CCFP's partnership with WONCA. The Caribbean College of Family Physicians recognizes the importance of collaboration in addressing global health challenges. CCFP is a proud member of the World Organization of Family Doctors, or WONCA, a federation of 131 member organizations representing over 500,000 family doctors worldwide. This partnership with WONCA provides CCFP members with access to a global network of family medicine professionals, fostering the exchange of knowledge, best practices, and innovative healthcare solutions. It also allows CCFP to contribute to the development of international standards for family medicine education and practice. CCFP's commitment to regional action is evident in its active involvement in shaping health policy in the Caribbean. The organization has been instrumental in key health policy meetings, including the Nassau Declaration on Health and the Port of Spain Declaration. These declarations address critical health issues facing the region, such as non-communicable diseases and the social determinants of health. By actively engaging in regional and global health policy discussions, CCFP ensures that the voice of Caribbean family physicians is heard and that the unique healthcare needs of the region are considered. If you are a family physician committed to improving the health of the Caribbean people, we encourage you to join the Caribbean College of Family Physicians. CCFP membership offers numerous benefits, including continuing medical education, professional development opportunities to enhance your leadership skills, advocate for your patients, and contribute to the development of healthcare policies. Research and publications. Global connections. Join the Caribbean College of Family Physicians today, whether by direct membership, by chapter membership, and be part of a movement that is shaping a healthier future for the Caribbean. Together we can make a difference. Become a member and make a difference.